important studies which were conducted in India, 2 large community-based studies, randomized control trials which were conducted in India. So this study, published in Epidemiology Infection in 2011, was one of the largest community-based double-blind randomized control trial that involved almost 4,000 children in the age group of 1 to 5 years, and was conducted by the National Institute of Cholera and Endemic Diseases and ICMR Institute in an urban slum of Calcutta. So these are some of the pictures of the study. As you can see here, they are being given the probiotic by the mothers, by the caretaker. So out of the 4,000 children, 3,758 children were included in the study. They were divided into the probiotic group and the nutrient group, which included 1894 children and 1864 children respectively. They were given the probiotic for a period of 12 weeks and then followed up for another 12 weeks. This is a slide which shows the isolation of enteric pathogens both in the probiotic and the nutrient group. And as you can see here, Aeromonas species and Cryptosporidium were significantly lower in the probiotic group as compared to the placebo group. But there was not much difference in the different enteric pathogens in the two groups, that is the probiotic and the. So this slide tells us that 608 subjects had diarrhea in the probiotic group as against 674 in the nutrient group. And the level of protective efficacy for the probiotic was about 14%. There were no adverse effects in children of either probiotic or nutrient group, and the study concludes that daily intake of a probiotic drink can play an important role in preventing acute diarrhea in a community setting of a developing country. Now, we all know that neonatal sepsis is a major cause of morbidity and mortality in neonates, especially in developing countries like India, and fatality rates are as high as 5 to 60% even with antibiotic treatment. Now, this is a large community-based double-blind placebo-controlled randomized trial that evaluated the efficacy of a symbiotic preparation in preventing neonatal sepsis in rural Indian newborns in 149 villages of Orissa. The neonates were at least 2,000 grams at birth and 35 weeks gestation, and they had no signs of sepsis or any other mortality. So these are some of the pictures of the neonates who were taken for the study, who were included in the study, and you can see the condition of health of these neonates. So 7,089 births were screened in the study villages, of which 4,556 or 64% were enrolled in the study. 2,278 neonates were allocated to the symbiotic arm and the remaining 2,278 to the placebo arm. All infant and maternal variables were distributed similarly between placebo and treatment groups at the baseline. The symbiotic L-plantarum and fructooligosaccharides was administered orally to the newborns for 7 days, beginning day 2 to 4 of life or 24 to 36 window period. The neonates were monitored for 60 days. Of the 4,556 infants, 319 infants were recorded as sepsis based on the WHO criteria by the physician. There was a significant reduction in the primary combined outcome of neonatal sepsis, with 9% in the placebo arm to 5.4% in the treatment arm, resulting in a 40% reduction. Each of the three components, culture positive sepsis reduced by 82% for gram positive bacteria and 75% for gram negative bacteria, and culture negative sepsis reduced by 47%. The lower respiratory tract infections reduced by almost 34%. So the study showed that there was significant benefit of the symbiotic in reduction of neonatal sepsis in healthy neonates in India, significant reduction in lower respiratory tract infections, which is as important as prevention of clinical or culture positive sepsis, substantial reduction in variety of other infections, which was the value of this intervention, and finding of a number needed to treat of 27, suggesting that $27 was needed to prevent 1 case of neonatal sepsis, which would otherwise be very, very expensive. So does probiotic consumption reduce antibiotic utilization for common acute infections? This is a systematic review and meta-analysis. So this included 17 randomized controlled trials which were conducted on infants and or children. preventing and probiotics were used to prevent acute respiratory tract infections, acute lower digestive tract infections, or acute otitis media. There were 13 probiotic formulations comprising of single or combinations of lactobacillus and bifidobacteria. The duration of probiotic supplementation was from 4 days to 9 months. And the conclusion of the study was that infants and children who received probiotics to prevent acute illness had a lower chance of being prescribed antibiotics relative to the placebo group. So there are global recommendations for the use of probiotics by the World Gastroenterology Organization, World Allergy Organization, European Society for Pediatric Gastroenterology, Hepatology and Nutrition. So the World Gastroenterology Organization recommends the use of specific strains of probiotics for different GI disorders. World Allergy Organization recommends use of probiotics for allergy prevention, probiotics during pregnancy, breastfeeding, in weaning products after exclusive breastfeeding. And the European SFAN suggests that they do not associate probiotics with any kind of adverse effects for use in children. So this brings me to the last slide, which is the enemy of my enemy is my friend. This is an ancient proverb which suggests that two opposing parties can or should work together against a common enemy, which is antibiotics. Thank you, and I'll be happy to take any questions.
I want to thank Nirja ma'am for this very informative and thought-provoking presentation. Thank you so much, ma'am, for this. Thank you for your patience. Now we are going to start the talk of Dr. Malini Kapoor ma'am on the topic of emergence of emergomycosis.
Good afternoon, everybody. At the outset, I would like to thank the RAJMICROCON organizing team, Dr. Rama Chaudhary, Madam, for inviting me for this talk, Emergence of Emergomycosis, Diagnosis and Treatment. Fungi, they are masters of survival since 1 billion years. They were surviving even after the asteroid strike, climate change, the pandemics, the recent one being COVID-19. And over 300 million people are affected by serious fungal infections. And if you look at the mortality, it's comparable to that of tuberculosis. But what is the awareness, or is there any national program on it? And if you look at the endemic mycosis, the most prevalent one, endemic mycosis, are histoplasmosis and telleromycosis. And so what about emergomycosis? This is a recent endemic mycosis, and it is often a missed diagnosis and iceberg disease. It masquerades clinically and radiologically like that of tuberculosis. And these endemic fungi, they can cause havoc during the pandemic, especially COVID. You could see fungal pneumonias caused by these endemic mycosis. Now, these are not geographically restricted due to global factors such as migration, increased travel, and climate change. And ILO had commented that much is known about histoplasmosis, but what about other endemic mycosis? And that still holds true. And in the WHO fungal priority pathogen list also, there is mention of histoplasma, there is mention of coccidioides, telleromyces, and no mention on other endemic mycosis. And if you look at the endemic mycosis, the host factors are not applicable. In a given clinical or the compatible clinical illness, there is evidence for geographical or occupational exposure. Mycological evidence is in the form of antigen or antibody, and it could be culture also, and histoplasma or blastomyces antigen in urine, serum, or body fluids. And there's a cross reaction of the antigen of emergomyces with that of histoplasma. So what is this newer emerging endemic mycosis? It's a systemic fungal disease caused by the thermally dimorphic fungus, and it has got Emergomyces pasturinianus as the most widespread species, and Emergomyces africanus in the highest incidence in South Africa. More than 154 cases have been reported, and Emergomyces canadensis, Emergomyces orientalis, Emergomyces europaeus. And the taxonomic revision in the family Ilomycetia, it was reported after the ribosomal DNA sequencing of all Emboncia-like fungi. A separate genus Emergomyces was created. It is differentiated from Emmoncia species, especially Emmoncia parva and Emmoncia crescens, by having small budding yeast cells and no thick-walled adiaspore, as is seen in the picture. It can cause emergomycosis, can cause disseminated disease with extensive cutaneous involvement in immunodeficient patients. Therefore, it is very, very crucial for the clinicians and microbiologists to be aware of such differences to avoid misdiagnosis. It can cause disseminated fatal disease in immunocompromised patients across Asia, Europe, and Africa, North America with clinical manifestations. And if you look at this world map, it was first reported in Italy in 1998, again confirmed on PCR, and whereas the patient presented in 1992, followed by Germany, France, Spain, Netherlands, then South Africa, India, Canada, America, and China. The origin, in 1970s, there were infections caused by the Ilomycetes family, and in 2017, the global collections, it was reanalyzed. The genetic analysis was done of the ribosomal DNA sequencing. There was a taxonomic review. Majority of the known systemic thermally dimorphic fungi of the order Onigenales, that is the Ilomycetes family, they belong to the genera Blastomyces, Emontia, Emergomyces, Histoplasma, and Coccidioides. And these differ in host, virulence, survival, and replication in mammalian host. And if you look at in this figure, it is the Emergomyces only which has got a human host, and it can have a host body temperature of 36 to 37.5 degrees centigrade. And this is the slide showing the phylogeny, ecology, and taxonomy of systemic pathogens and their relatives in Ilomycetea. And so these organisms, they share the inhalation of propagules, pulmonary and extrapulmonary disease, cell-mediated immunity, endogenous reactivation, and all show thermal dimorphism, and they are endemic mycosis. So the earliest case was reported in 1992 Italy, though it got published in 1998. Atypical disseminated mycosis, female with advanced HIV with cutaneous lesions, and on histopathology, budding E cells were seen which was similar to Histoplasma capsulatum with no adiospores, and culture was unlike Histoplasma capsulatum florets with swollen conidiophores. This we got in our cases too. Genetic analysis related it to Emontia crescens, which was renamed as Emontia pasteuriana in 1998. And in 2017, there was a taxonomic revision and it was renamed Emergomyces pasteurianus, and 10 cases have been reported, including 2 from our center, including from the other Asian countries like China, then in Europe also, and Africa also. So this is our first case, a 38-year-old female, Nepal, a cleaner for 3 years in Delhi with pulmonary tuberculosis. It presented to us in 2012 with weight loss, dyspnea, chest pain, multiple non-tender skin lesions on face and body for 3 months. The chest x-ray showed bilateral consolidation more than left than on right. An HRCT showed multiple nodules and lymph nodes. The CT-guided FNAC showed intracellular and extracellular yeast cells, which were PAS positive, and GIMSA and gram stain showed the histopathological evidence also. And and this is our second case, disseminated Emergomyces pasteurianus infection in India. That is a 27-year-old female, Muzaffarpur, Bihar, since 8 years in Delhi, fever, cough, skin lesions. And the patient was HIV positive. The CD4 count was 38 cells microliter, and the ESR was 50. An HRCT showed bilateral consolidation, lymphadenopathy. The abdominal CT also showed the involvement of periportal and pancreatic lymph nodes. The FNAC and the histopathological examination of cutaneous lesions showed intracellular and extracellular budding yeast cells, skin lesions, the blood, and the bone marrow aspirate culture showed growth. A white, moldy, and a restricted growth was seen. The patient was treated, both the patient induction with liposomal amphotericin B for 2 weeks, followed by itraconazole. And there was a prompt resolution of signs and symptoms after 1 year of therapy. Now, slide culture. Slide culture showed thin hyaline septate hyphae with slender conidiophore with terminal conidia and florets. Dimorphism, the yeast transformation was seen on the brain-heart infusion-based blood agar at 37 degrees centigrade. After 21 days, small budding yeast cells with narrow base blooding was seen. Patient was given amphotericin B induction with itraconazole, and the MIC value point mentioned in CLSI. Emergomyces africanus, 2013, it got published. 13 patients with HIV, mostly from South Africa, West Cape. Phylogenetic analysis of 5 gene LSU, ITS1 and 2 beta tubulin, actin and intin PRP8. The fungus closely was related to Emergomyces pasteurianus, The genetic analysis based on the DNA sequence renamed it to be Imago-Myces africanus. And there are more than 154 lab confirmed cases, mostly reported from HIV patients. Imago-Myces orientalis has been reported from China, 2 cases, Imago-Myces canadensis, 2 retrospective cases, and 3 prospective cases have been reported. And this is the recent one from Canada showing the granulomatous lesions in the lung. And Imago-Myces europaeus is reported mainly from Europe and Germany, and it was reported that this is the only Imago-Myces species which can cause only the pulmonary infections. But if you look at most of the other can cause pulmonary and extrapulmonary infections. And is there an ecological niche for Imago-Myces? This was started by the South African group, which they found that Imago-Myces africanus, like in the mycelial phase, 30% of soil samples it was isolated, and especially the soil which was involved in agriculture and horticulture activities. And Imago-Myces africanus was reported, especially its DNA was reported in 10% of air samples collected in Cape Town. And so that means in culture it was never isolated, but yes, the DNA was found from the environment. Pathogenesis, the virulence factor genes are conserved in Imago-Myces pasteurianus and africanus. The pathogenesis is not completely understood, and the Imago-Myces pasteurianus, africanus, and Imago-Myces europaeus, they are urease positive, which acts as a virulence factor, and then there are host susceptibility also, which is involved. But further studies are warranted. Now, if you look at the clinical manifestations, the primary route of infection is inhalation, airborne conidia, saprophytic mycelia in soil, and human host tissue. The conidia, they get transformed into yeast, replication, and extrapulmonary dissemination. Now, all have been reported in immunocompromised adults. In the late stage of HIV infection, the risk factors include neutropenia, solid organ transplant, immunosuppression, and hematological malignancies. The multi-system disease involves the skin, lungs, liver, spleen, bone marrow, and lymph nodes, brain, and cervix. So if you look at classically, the patient will present to you with fever, weight loss, dyspnea, pulmonary signs and symptoms. 96% of the patients with disseminated disease will present with the cutaneous lesions with very low CD4 count, severe anemia, and similarly we got the picture in our cases too. Risk factor included HIV, immunosuppression, and transplant. And these are the classical lesions. We got, nodulo ulcerative lesions in this. They're different from that of histoplasma. And so you can see all the major systems are involved, and the CT scan findings show diffuse and focal reticular nodular infiltrates, consolidations, lobar atelectasis, effusions, and hilar lymphadenopathy. Diagnosis. Now, diagnosis is based on histopathological examination, chronic granulomatous or suppurative dermal inflammatory. It's there with multinuclear giant cells, histiocyte plasma cells, intracellular yeast cells, and 2 to 4 micrometer narrow-based budding. Now, the fungal culture tissue biopsy will show the budding yeast cells, intracellular and extracellular, and you can have all other samples too, like blood, skin tissue, bone marrow aspirate, lymph node aspirate, induced sputum, or bronchoalveolar lavage. So on histopathological examination, you could see the budding yeast cells on H&E, and even on Brockett methenamine silver also, and per-iodic acid SCIF also, PAS positive yeast cells will be seen. Now, the fungal culture, the more microscopy, the mold phase, it shows slender conidiophores, swollen at the tip, short secondary conidiophores bearing florets of single-celled conidia, and on dimorphism experiment, they would convert to yeast phase in 2 to 3 weeks time. And this is the lab diagnosis. This is the classical picture, the florets and the swelling of the conidial tip. which is seen much appreciated on electron microscopy. In our second case, we could appreciate that on even light microscopy also. And now molecular identification, there is no commercially available molecular diagnostic test. The tissues, the fungal cultures, if they are negative, then the PCR is attempted, and using the ITS1, 5.8S and ITS2 of the ribosomal DNA, and broad range fungal PCR sequencing is required for identifying the fungi in FFPE tissue, and serodiagnosis is no sensitive or specific test available, but definitely there's a cross reactivity with histoplasma antigen. This is an example, the cross reactivity of histoplasma capsulatum antigen enzyme immunoassay in urine specimen for patients with imago-mycosis in South Africa. And so what is the differential diagnosis? Why it is often missed? Because there are so many differential diagnoses, and I'm sure it's an iceberg disease in India too. Like histoplasmosis, it would be sporotrichosis, blastomycosis. Clinically, the fever is just like that of histoplasmosis, fever, weight loss, anemia, and skin lesions. The cutaneous lesions resemble that of varicella, papillary lesions of HIV, secondary syphilis. Chest X-ray, the pulmonary lesions are just like that of pulmonary tuberculosis. And the histopathology, the yeast would be seen, which is unable to differentiate between the different fungal genera. So therefore, post-culture sequencing becomes the gold standard. On morphology, the mold phase of Emergomyces africanus resembles that of Sporotrichs, whereas the yeast phase of Histoplasma capsulatum, Emergomyces orientalis, resemble Blastomyces dermatitis. So this is a case of histoplasmosis. Definitely intracellular, extracellular yeast cells from the skin lesions and the bone marrow aspirate, but the mold form showed tuberculate macro. So this is a classical case of histoplasma. These are other cases, the lesions are different, but on histopathology it is similar to that of histoplasmosis, but the culture clinches the diagnosis. They are serological tests which will be cross-reactive. These are our cases of teleromycosis. Again, the skin lesions are different. The classical presentation is similar, and the diagnosis we attempted, and we found septate yeast cells, intracellular and extracellular. Extracellular, you can appreciate the septa. The intracellular, the budding yeast cells are there. And this is the lab diagnosis. Culture grew a fungus which was a dimorphic fungus, that is Teleromyces marnefi. Blastomycosis, clinical manifestations are similar. The laboratory diagnosis, again, the shape of the yeast cell is figure of 8 appearance, and culture is very classical. And this is what you see on culture. And it's resembling lollipops, and the yeast face is thick-walled yeast with a figure of 8 appearance or the single. And now intermingle is a very interesting article from South Africa. The geographical conditions of South Africa is quite common, and our the heterogeneity in population is very common in India also, in South Africa, very similar countries. So they reported that when they studied the endemic mycosis, that substantial fraction of the cases may remain undiagnosed. They could diagnose sporotrichosis, emergomyces, histoplasmosis, blastomycosis, teleromycosis. But what interesting finding they got was, like if in 2010 the incidence of like emergomycosis was less, that of histoplasma was high, but wherein the histoplasma incidence was less, the Emergomyces incidence was high. So this is a very interesting, means you are able to diagnose by PCR sequencing emergo. So I'm sure we are missing that in India too. Antifungal susceptibility, there are no breakpoints in CLSI, also in UCAST. And if you're using the mold or the yeast form, you need to have a larger inoculum for mold samples, like the 2 McFarlane. Incubation period should be 7 days. And if you look at the efficacy of antifungal, the induction with amphotericin B followed by itraconazole for 1 year, and itraconazole has been added in the WHO's essential medicine list. So treatment is as per the IDSA guidelines, and these are the global guidelines for diagnosis and management of endemic mycosis. Induction with amphotericin B followed by itraconazole, not fluconazole. So that's very, very important when you're diagnosing a case of emergomycosis. Induction with amphotericin B followed by itraconazole. Of course, there are new drugs also in the pipeline, especially tried by the South African group, posaconazole. Echinocandins lack efficacy. And what is the optimal timing of starting ART? ART is initiated 14 days after starting the amphotericin B, and then de-escalation to itraconazole. And future prospects in the drugs, we have super bioavailability itraconazole, and there is also a novel real-time quantitative PCR assay type, which is based on the emergomycosis mitochondrial gene. And to conclude my talk, greater awareness is warranted amongst the clinicians and microbiologists, especially for diagnosis and therapeutics. And differential diagnosis, they are vast: histoplasmosis, porotrichosis, blastomycosis, tuberculosis, and it's fatal, if especially in HIV patients. And histopathological correlation, fungal culture, and molecular techniques are of paramount importance. Culture followed by the sequencing of the broad range fungal targets. And in HIV patient, it may present as an unmasking of the iris in form of new or worsening skin lesions. As far as the AFST is concerned, no CLSI approved standards, larger inoculum for mold, and clinical management is limited to induction with amphotericin B followed by itraconazole for 1 year. And there is super bioavailability itraconazole. The knowledge gaps include in the geographical distribution, biology, and pathophysiology. The true burden definitely is underestimated. These are all iceberg diseases because of lack of mycology lab, the molecular diagnostics. So here I would end my talk with, if you hunt, you will find, otherwise you will not. So you look out for it. It comes under the iceberg disease. Have your basics right, the microscopy, the cultures, and cultures then followed by post-culture sequences. You can take help of the reference lab. So thank you. With this, I end my presentation. Thank you, everybody.
Thank you so much, ma'am, for this informative talk. Now, I would like to invite Dr. Rama ma'am to give mementos to Dr. Malini Kapoor ma'am and Dr. Nirja ma'am. I invite Dr. Manju ma'am to take mementos on their behalf. A very good morning to everyone. After the successful and informative first day of 2nd RAJMICROCON 2023, I welcome you all on the day 2. It's been a great honor and opportunity for all of us to host this event. Moving forward to the session 3, that is syndromic approach, I invite our respected chairpersons for this session. I invite Dr. Pallab Ray sir, Professor, Department of Medical Microbiology, PGIMER, Chandigarh, ex-HOD, PGI, Chandigarh. Sir is world-renowned name in the field of microbiology and research with various projects and publications. Dr. Hema. I invite Dr. Nitya Vyas ma'am. Madam is Senior Professor, Department of Microbiology at Mahatma Gandhi Hospital and Medical College and former Professor and Head at SMS Medical College, Jaipur. Madam has various publications and projects in her name and very rich experience in the field of microbiology and research. Now I would like to invite Dr. Hema Kapoor ma'am, Senior Medical Director for Infectious Diseases and Immunology and the Global Diagnostic Network Medical and Science Advisor HK Healthcare and Consultant LST DOE, Florida. I would like to invite Dr. Manju Mala ma'am, Apex Regional STC Center, VMMC Safdarjung Hospital, New Delhi. I would like our honorable chairpersons to introduce the ma'am and start the session.
I think it's I'm introducing us. I am introducing Dr. Manju Bala. She is from Apex Regional STD Center, BMMC, Safdarganj Hospital. I think all the other information about Dr. Manju Bala has been displayed here. And will someone read that out? Acha, okay, that's good. So we can proceed with your deliberations.
Thank you, Dr. Nitya. Good morning, chairpersons, esteemed faculty of the dais, and dear friends and colleagues. So I am thankful to Dr. Rama and her organizing team for giving me opportunity to talk on this STIs, the topic which is very close to my heart, and I am working on it for the more than 28 years. So I will be talking about what is happening for the STIs at country level, and then also at our Apex Center, and what is the syndromic approach, and then the lab-assisted approach also. So this is the organization structure for STIs in India. NACO is there at the top, and it has decentralized this activity by giving it to state AIDS control societies in different states, and then is their Apex STI Reference Center at Safdarjung Hospital, where I am working. And this Apex Center is linked to the 10 regional reference labs across India. And these 10 regional reference labs, they are linked to the 45 state reference labs in different states. And these 45 state reference centers, they are further linked to STI, RTI, and TI clinics. So what is the structure of this regional center or state reference center? There are 4 departments which are working in collaboration. Microbiology is the main department, and it is further working in collaboration with the STI, RTI clinic in skin and STD department, with the designated STI, RTI clinic in gynecology and public health division. Center at Safdarjung Hospital, which is Apex Center, we are also having one regional reference lab, so we are having the dual responsibility at Safdarjung Hospital. As Apex Center, we are doing the capacity building of the regional reference labs in the country, and also providing the EQUAS panel across the country to different regional reference labs, to state reference labs, and to some other centers also. And as regional reference lab, we are doing the capacity building of our linked state reference labs, and then doing diagnostic research and surveillance. And we are having our STD lab, male STI clinic, female STI clinic, and mobile unit. And this mobile unit goes to peripheral health centers every alternate day, and we are having the state reference lab for HIV testing, which is further linked to all these ICT, CPP, TCT, ESTA. So there are different approaches to STI, RTI case management. One is the traditional clinical approach, where the clinician diagnoses by signs and symptoms. And then second is the syndromic approach, which is being recommended by WHO and NACO also. WHO is also recommending in the different countries, and NACO guidelines are there, and as per NACO guidelines, syndromic approach is being used in India. And then there is lab-assisted approach, where this network of the different reference lab, it comes into action, which I have already told you. What is this syndromic approach? Why it is being used? The reason is that on the basis of syndromes, that whatever signs and symptoms they are there, it is a comprehensive care package, and then the clinicians, on the basis of the syndrome, when the patient comes to the clinic, they diagnose it, and it also includes the counseling component, and it also includes so that we can treat the syndrome instead of waiting for the lab report, and then it will, because STIs, they are being stigmatized, and patients, they are reluctant to come to the clinic. So sometimes first visit is the last visit. So we have to address them at that time only. That is why this syndromic approach is advocated, so that we can treat at the same time, and then there is no further transmission to the transmission of infection to their partners. And then it also includes partner tracing. But there are disadvantages because when we are doing the syndromic management, we are giving the over-treatment because we are giving the combination of antibiotics. And then because of over-treatment, there are side effects and then AMR, which we all microbiologists, we are familiar with this fact that whenever we do over-treatment, there is AMR. What is the syndromic approach? In this workflow charts are there for these 6 syndromes. Earlier there were 7 syndromes, but as per recent NACO guidelines, there are now 6 syndromes. One is urethral discharge syndrome, where NG, CT, and Mycoplasma genitalium and Trichomonas, they are responsible. Genital ulcer disease, which includes syphilis, chancroid, and LGV. Then vaginal discharge. Under it, vaginal infection and cervical infection. Earlier, they were under different syndromes, but now they are combined under vaginal discharge. Vaginal infection due to Trichomonas, Candida, bacterial vaginosis. Cervical due to Neisseria and Chlamydia. Lower abdominal pain, again, NG, CT, and anaerobes. Anorectal discharge, it can be presented as discharge, as pain, or as an ulcer. In discharge, there is NG, CT, and in pain, HSV, and in ulcer, ulcerative agents. So painful secretor swelling, again NG and CT. Then there is enhanced syndromic case management. Because we know that in most of the district hospitals and peripheral centers also, a technician is there, microscope is there, and the rapid test they can be carried out. And we can have the report immediately, like gram staining, GIMSA staining, they can be done. And wet mount can be done, even point of care tests they can be done, and the report is immediately available. So when the simple and rapid tests, they are included and they are combined with the syndromic management, this is enhanced syndromic management. So what are the different etiological agents of genital discharges, genital ulcer, genital discharges? This is Neisseria, Chlamydia, ureaplasma, mycoplasma, which can cause non-gonococcal urethritis, mucopurulent cervicitis. Trichomonas vaginalis, which causes vaginitis and NGU. Candida albicans, again same. Gardnerella vaginalis and other anaerobes which are responsible for bacterial vaginosis. Then for genital ulcers, Treponema pallidum, Haemophilus ducreae, Klebsiella granulomatis, which is responsible for donovenosis. But you will see that nowadays syphilis is prevalent, but chancroid again is diminishing. Whatever we used to come across 15 years back, 20 years back, we now hardly see around 1/20th of chancroid, and donovenosis is almost obsolete. Maybe we come across only 1 case every 2 or 3 years. And herpes simplex, viral infections, they are increasing, like herpes simplex, herpes progenitalis, because reason is they are difficult to treat and they are recurrent. Bacterial infections, they are curable, and these viral infections, they can't be cured, and latent infection is there, so whenever immunity is down, there is recurrent infection. Then LGV due to Chlamydia trachomatis. But there can be some less frequent causes like scabies, non-syphilitic spirochetes, and some non-infectious causes, and some other STIs like HIV/AIDS, hepatitis B, C, human papilloma virus, genital warts. These are again increasing a lot, genital warts, molluscum contagiosum. So I'll be talking briefly about lab diagnosis of each and every STI, and what are the facilities available at our Apex Center. So whatever I am talking about, all the facilities, they are available at our Apex Center, and we are doing the capacity building of our regional reference lab for diagnosis. So whenever there is any case of gonorrhea with purulent urethral discharge, a sample is collected, and that can be from urethra, because males, they present with this, you can see that urethral discharge, this is mucopurulent cervix in females. Then ophthalmia neonatorum, which is now almost, you don't come across these cases because it can be treated very well with the, whenever mothers, they are pregnant, and at the birth of child it used to happen, and now it is not happening because these are all curable things. But if we leave anything untreated, then the infection can spread to the other organs, and there can be disseminated gonococcal infections, like there can be joint involvement and other disseminated infections. So sample can be taken from urethra in male and in female, and in females also from endocervix, and in homosexuals from rectum, and in females where hysterectomy is done, then vaginal swab carries importance, and in homosexuals, again, oropharyngeal swabs, they carry a lot of importance. So sample once collected, it should be either bedside inoculation, it can be carried out, and smear can be made bedside, or it can be transported to the lab in the transport media. So there is direct detection of the organism or culture. So we are doing direct microscopy because our clinic is adjacent to the lab on the same floor. So this is the very unique setup in our center. Otherwise, you will see in that most of the medical colleges, that clinic is far off, around 1 kilometer, 2 kilometer in the college campus from the laboratory, and sample transport, sometimes it is not done. And we see that even in sometimes regional reference lab and state reference labs, the clinician, they are not sending the sample to the microbiologist. That is how we, whenever we do the supervisory visits, we ask them that there should be proper linkage between these different departments, because we should be doing the etiological validation also, so that we know that whenever we have to change the treatment guidelines, we are having the data available, and then we can change the treatment guidelines as per data available from these 10 regional reference labs and 45 state reference labs across the country. So culture, because gonococcus is difficult to grow, it is a bit fastidious organism, and you need 35 to 36 degree temperature and carbon dioxide for its growth. And once the culture colony is there, then we can differentiate, we can do the presumptive identification by colony morphology, and by, in the smear, these are intracellular gram-negative diplococci, and from the colony you will be seeing only gram-negative diplococci. And once it is there, gram-negative diplococci, you can do the superoxole and oxidase test. And confirmatory test is rapid carbohydrate utilization test. All these facilities, they are available, and we are doing hands-on training of the labs on all these tests. And once the culture confirmed, then we are carrying out the antimicrobial susceptibility testing by CDS technique, that is Australian technique, and then CLSI technique, and also by MIC, by e-test strips. And we are publishing continuously the AMR patterns from our lab also, and from the country network also, and from the Southeast Asian countries also, because ours is WHO reference lab for Southeast Asian countries for gonococcus. And we are also carrying out the GC EQUAS at country level, and we are participating in the international EQUAS, which is being conducted by WHO Collaborating Center Australia. And since 2000, for the last 23 years, we are participating in this EQUAS, and we are also conducting this EQUAS for the last 22 years. And 18 labs we are sending the panel, which includes the 10 regional reference labs and linked state labs. And we are also carrying out the retesting of the referred NG isolates. And we have published that how the EQUAS, participation of the labs in EQUAS, how it increases their performance over the years. About the non-gonococcal urethritis, commonest etiological agent is Chlamydia trachomatis, and then there can be ureaplasma, mycoplasma genitalium, and hominis, then herpes virus, and in 40 to 50% cases, etiology is unknown in NGU. And then mucopurulent cervicitis, Chlamydia trachomatis in 60 to 80%. And for genital chlamydial infection, whenever one has to take this swab, we keep on talking to the clinicians also that they shouldn't be taking the discharge. Otherwise, like in gonococcal, we take the genital discharge, but not here in chlamydial infection. It should be urethral and cervical scrapings. It is very important that when the lab, they are doing the test, and positivity of the test will depend upon the sample collection. So this urethral and cervical scrapings, that clinician, they have to rub the urethra and cervix and then take these samples, and so that it includes the columnar or transitional epithelial cells. And swab sample should be taken before antibiotics. And whenever the patient comes, the holding time of the, like even in gonococcal infection, patient shouldn't have passed urine for 1 hour at least before we take the sample. And the sample is transported to the lab in the transport media. And different diagnostic techniques are there. Culture is there, that is tissue culture, but we are not carrying out the tissue culture because it is a cumbersome technique. And then there are non-culture techniques, that is DFA for antigen detection and ELISA for antigen detection. We are doing both the techniques in our lab, and then NAT also facility is there in our laboratory. We are asking NACO also to include in the guidelines that the NAT should be carried out in the regional reference labs. And then point of care tests, they are available, like Gene Expert for gonococcus and chlamydia, it is available. Then there is one term, because culture is the, tissue culture is the gold standard for chlamydia, and it is not being done only in the research laboratories it is carried out, and for diagnostic purpose it is not being carried out. There is one term which is known as expanded gold standard. So here we can carry out NAT, and then it can be confirmed by another NAT which is targeting the another different target, or by DFA or ELISA for antigen detection. Then Trichomonas vaginalis. So here the patient presents with the foul-smelling vaginal discharge, and the discharge specimen, when it is taken from the posterior fornix, if the specimen transport to the lab is delayed more than 2 hours, then we can transport it in the MES transport media. If it is less than 2 hours, we can transport it in the 0.3 ml of saline. So microscopy in our lab, in our setup, we are doing at the clinic level itself only, because clinic is adjacent. Even in gynecology, we take the microscope and do the microscopy over there only. And then we are doing the culture by Kupffer bug media. And we carried out in-pouch TV culture also to compare, because in-pouch TV culture is a bit easier to process than the Kupffer bug media or Whittington media. So we wanted to know that how much sensitivity is there, because this in-pouch TV culture is more expensive than Whittington or Kupffer bug media. We found out in our study that the sensitivity is almost same. Although slight ease is there in handling the in-pouch culture, but cost effectivity is also a major factor. So that is why we still stick to the Kupffer bug media. We are not recommending to our labs in-pouch culture. Reason is because it is very cost effective when we are using the Kupffer bug or Whittington media. Then bacterial vaginosis, we are doing the diagnosis both by EMSL criteria and Nugent scoring. In EMSL criteria, from the clinical picture also you come to know that there is thin homogeneous adherent discharge. Then we are carrying out the pH test in our clinic itself, in STI clinic. If pH is more than 4.5, it is again suggestive, it is one of the EMSL criteria. And then WIF test or amine test, and then looking for the clue cells in the gram staining. So this is the WIF test when you do the, you are putting the amine, doing 10% KOH and looking for the amine smell. And then these are the clue cells. When the epithelial cells, they are covered by the organism so much that the margins, they are obliterated. So these are the clue cells. So for Candida, although these are the topics where one can speak for 1 hour on each topic. So, but I am just being brief to give you an idea that what are the facilities available in our country. And if people want to establish anything, we are always available to do the capacity building. And then we are doing the microscopy, we are doing the gram staining, direct wet mount also we are looking for, and after gram staining also. And then culture on SDA, and we are doing the germ tube test to know whether it is Caldina albicans or some other species, and then doing the speciation also, and doing antifungal susceptibility testing. So when you see the wet mount, which we are doing in the, which can be done in any STI clinic, so one is normal epithelial cells, and these are the clue cells. We can look for bacterial vaginosis also in the wet mount. And then these are Candida, that you can see the budding cells, and then the Trichomonas vaginalis. So these are all rapid tests which can be carried out in any STI clinic, in any district hospital, even in PSCs. And one can make the diagnosis which is known as enhanced syndromic case management, which I talked to you in beginning. So for syphilis, dark field microscopy is there, which we are carrying out. And the clinician, they take the samples from primary syphilis cases and from secondary syphilis cases, and then they are sending the mount to us. And our technician also goes to the clinic at that time. And then we are also doing the all serological tests, like non-treponemal test. We are having this facility for VDRL, RPR, all treponemal tests also, TPHA, FTA, ABS, ELISA, and rapid point of care test. Reason is being Apex Center, we want to establish the facility for everything, and we are also participating in CDC EQUAS for all these tests, so that we know that where we stand, and we are getting 100% score for all these tests. Dark field microscopy, one has to be very careful while taking the specimen, and then we have to differentiate the motile treponemes from the other non-treponemes, because you see other treponemes also, and they have to be differentiated by their morphology and their motility. Because treponemes, they are having the regular spiral, while the other treponemes, they are having the wide irregular spirals, and their motility is also different. That treponemes, they are having very majestic movement when you see under dark field microscope. But these other treponemes, they are having the lashing motility, and they just move out of the field immediately. So we are easily able to differentiate these two types of the treponema pallidum and other treponemes. And then serological tests, there are two types of algorithm for diagnosis, that is traditional algorithm. As per NACO guidelines for diagnosis, we are following the traditional algorithm in all the reference labs, and even on all the some of the medical colleges where they are having the TPHA facility also, that we can carry out VDRL and RPR, then the confirmation by the TPHA test. But now STI surveillance, it has been initiated by NACO across the country, and where we are doing the surveillance for syphilis also. Here the reverse algorithm is being followed. In other Western country also the reverse algorithm is followed, where we are doing the treponemal test. And here in our country, we are doing the TPHA test as the first test, and if the test is coming positive, then to see whether it is active syphilis or not, then VDRL or RPR is being carried out. Here RPR, because it is a surveillance thing, and RPR is easier to carry out. And we are participating in the quarterly CDC EQUAS of Atlanta, USA since 2012. And we are conducting national level EQUAS since 1999, and 37 labs at present they are participating, including regional labs and state reference labs. We are carrying out the retesting of the referred serum samples, which we are receiving from our state labs and from regional labs. And we also published this syphilis EQUAS result, how the performance of the labs, they improved over the years. So this is the sensitivity and specificity of various STS, which all the microbiologists, they are aware, and I won't be talking about, considering the constraint of time. And because whenever we are talking about biological false positive of VDRL and RPR, we should be very aware, because people, they mostly think that titer equivalent to 1:8 or more than 1:8 is the titer which we should be taking for the diagnosis of syphilis. But what we have seen, our experience at Apex Center, that many cases, around 60 to 70% cases, they are having titer less than 1:8. We are having around 40 to 60 cases per month, we are getting VDRL, RPR positive. And around 60 to 70%, they are having titer less than 1:8. And 90% of these cases which are having titer less than 1:8, TPHA is positive in these. So either these are latent cases, because if titer is less than 1:8 and TPHA is positive, or maybe they are treated cases of syphilis. That we have to diagnose from the history taking, proper history taking. So that is why there are some fallacies, and we have to overcome, and we have to be very particular in the history taking and the interpretation of our results also. For chancroid, we are having the facility for gram staining, where you can see school of fish appearance or railroad track appearance. And then, but this gram staining is having low sensitivity and specificity. So we are having also facility for culture, but Haemophilus ducreyi is very difficult to grow, and now chancroid cases, they have really declined over the years. Maybe in a year we hardly come across clinically 4 to 5 cases of chancroid. And we require specific temperature, 32 to 33 degree, and carbon dioxide is required, and minimum incubation period is 48 hours, and we can prolong it to 72 hours or longer. And then presumptive identification is by Colli morphology, by gram-negative coco-bacilli on gram staining and beta-lactamase detection, and definitive by oxidase test, nitrate test, alkaline phosphatase test, and positive catalase test. Then for herpes, we are doing in routine, any case of ulcer wherever it is there, we are taking the specimen for dark ground microscopy also, and then zinc preparation for herpes genitalis, where the GIMSA staining is done, and we are looking for the inclusion bodies, and we are looking for MNGCs, and then we don't have tissue culture facility, but we are carrying out ELISA, and we are having the immunofluorescent test also sometimes available with us, but we are having the NAT facility. Now we have established NAT for many STI markers like chlamydia, mycoplasma, ureaplasma, herpes, genital warts, and all these things. Then donovanosis, I told you that it is almost obsolete, but we are looking for the donovan bodies, and presence of mononuclear cells itself is quite suggestive of that there can be donovanosis. So whenever we receive the smear and whenever we see plenty of mononuclear cells, we keep on looking for the donovan bodies, and sometimes because they are less in number, and thorough examination of the smear helps in the diagnosis. Then genital warts, we are doing the HPV detection, and we are having the NAT facility, and we are looking for the high-risk genotypes and for the low-risk genotypes. And this is the most advanced procedure, and although there are some other procedures also, but we are now depending on this. Thank you for your patience listening. Any questions?
Anybody has any question for Dr. Manju? Dr. Mirda?
Can I ask you a question? Manju? Achha. Manju, in one of your slides, you mentioned about the budding yeast cells, that they were speciated and then tested for antifungal agents. So, do you do it with Vitek or any other method?
No, normal. Antifungal susceptibility testing by e-test strips we are doing.
Okay. And speciation by?
Speciation by chrome agar and all these facilities,
Achha.
we are having everything.
Okay. Thank you.
Okay. From the dark ground microscopy, as you said, like you have a majestic movement for the treponema pallidum and non-majestic for the other non-treponemal. So how many non-treponemal treponemes have you seen during your dark ground microscopy over a period of time? How many?
Actually, it depends from where we are taking the specimen and how we are taking the specimen.
Okay.
And like when from the ulcer case, when they are taking the specimen and properly when we know that this is the, from the clinical picture we come to know, we see only treponemes. But like if you are seeing the pharyngeal specimen or all these some contamination is there, then sometimes we come across, not in routine because our clinicians, they are quite experienced in taking the specimen from the ulcer.
No, what I'm not trying to say that how many are treponema pallidum. I just want to know how many non-treponemal things do come during your examination. I just wanted to know.
From the ulcer cases, we are not coming across any.
Not coming across.
But
okay.
if we want to demonstrate to the, like during our workshops, we take the pharyngeal specimens and all these things, we are able to demonstrate.
Yeah. Okay, another question is just, like you have a primary syphilis or secondary syphilis.
Yes.
And you're likely to get less than even 1:8, which you consider that it should be considered. But once the person is clinically symptomatic, right, and the clinician has clearly diagnosed that this is a case of syphilis, so why this kind of flaws do come across even if you are going to reinforce with TPHA? So why do you feel, what are the dynamics that they go below 1:8 titer?
Actually,
In certain patients, yeah.
when the titer is less than 1:8, because when we are talking about primary syphilis or secondary syphilis, few cases they come with the classical clinical presentation, right? With the ulcer or secondary syphilis, they are coming with the rash. They have not reported, sometimes they don't report to the clinic with primary syphilis and they are straightway coming with the secondary syphilis. patient, they are not sometimes aware they had any ulcer. Because reason is we are, in our country, this off-the-counter, this treatment is easily available, and people, they take the antibiotics from, even if they are having some problem. And primary syphilis, and sometimes people, they take it lightly and it heals on its own, and people, they go into the secondary syphilis. And that is why when people, they are, because in our STI clinic, we are doing the screening for all the STI attendees. So that is why, because we have to know how many silent cases are there, how many latent infection, because they won't be coming, clinically they won't be presenting latent infection. And even we want to know that how many cases, if proper history, sometimes people, they don't divulge the proper history also to the clinician, even after complete frequent probing also. And then when we are doing the screening by these serological tests of all the STI clinic attendees, then we are coming across that VDRL is less than 1:8. And we have to put them in some category as the apex reference center, so that we are having the data available for the country. And then when we are doing the TPHA, and we are having the facility for other toponymal tests also, and we are correlating the results that how many TPHA, they are positive with FTABS and with the point of care test. And we have seen that the results, they are almost correlating for all the toponymal tests. And this, which the question like which you have put, if the titer is less than 1:8, so we feel that many of them, they are latent syphilis cases when we talk to our clinicians from the history taking. And some of them, they are treated cases of the syphilis, and that is why the titer is decreasing. And people, they have already taken the treatment, and then they are reporting the clinic. Then when we are doing the syphilis screening, titer is less.
Thank you.
Thank you.
Thank you, ma'am, for an excellent presentation. So I was just wondering, have we proposed to lowering the cutoff limit? Because most of the RPR standard tests which are available, they give a cutoff of 1:8 reactive.
Actually, this is what we are proposing to NACO, that at least at all medical colleges facilities, because our regional and reference lab, you will see these are only total 55 across the country, and this is not covering all the medical colleges. In the medical colleges, TPHA can be easily carried out. And I feel many medical colleges, they are not carrying out TPHA in routine. They are doing only RPR. So then we will have more data across the country. And because if we take it that only titer more, we are just doing, if I know at present this is being done at country level, that only RPR is being done.
Yes.
And if titer is equivalent to 1:8 or more than 1:8, it is taken as significant titer.
Yes.
And that is only considered as a case of syphilis. But then we are missing many cases of syphilis. This is what we feel from our data and from the other labs' data.
So then we should actively work towards changing the guidelines and changing in the kit manuals need to be changed.
Yes.
For reporting reactive.
Actually, NACO is keeps on working on this thing by involving the experts on STI experts across the country, and whenever we have to change the guidelines, and still we are thinking about it, that how we should be, because if the facility is established, only then we can have more wider data, and then accordingly. And now STI surveillance is running across the country, then we will be having the data, because earlier STI surveillance, it was carried out in 2002. And then there were patchy surveillance not across the country. So this is a big exercise which is happening now across the country. We will be having the more data, and accordingly then the guidelines, they can be changed, that what comes out from that data.
Thank you. Thank you, sir.
Okay, I think in the interest of time, we will proceed. Thank you, Dr. Manju, for such a...
Yes, ma'am, I need to say something. Actually, ma'am, the therapy, the testing you are talking about, at present, in this HSS, the HIV centralized surveillance, we did that. The reverse algorithm was followed. We did TPHA first. So, yes, NACO is now indulging in that. The reverse algorithm is going to be taken out.
That is what I said in my talk. Reverse algorithm is being followed for STI surveillance, which is running at present across the country. But as per guidelines in the diagnostic centers, in any diagnostic lab, traditional algorithm has to be followed as per guidelines. Thank you.
Thank you so much, ma'am, for sharing your experience and a very practical session. Now, I would like to invite Dr. Pallab Ray, sir. Sir is Professor, Department of Microbiology, PGI MER Chandigarh, and ex-HOD, PGI Chandigarh. Sir is world-renowned name in the field of microbiology and research with various projects and publications. Over to you, ma'am.
Can I have the presentation, please? Well, good morning, everybody. I'm very happy to be here in the second RAJMICROCON 2023. I was a part of RAJMICROCON first meeting also, and it always gives me a lot of pleasure to be here with the Rajasthan chapter of IAMM. Today, what we are going to talk about is biomarkers in sepsis. I know that we are running 1 hour or even more than 1 hour late. I won't take more than 20 minutes allocated to me. I'll be happy if I can save 5 minutes. I have a very bare bone presentation. So we are going to talk about biomarkers in sepsis. Let's first look at what is a biomarker. A biomarker or a biological marker is a property which is objectively measured or evaluated as an indicator of either a normal biological process or a pathogenic process or maybe response to therapy. And usually biomarkers are used for diagnosis, used for staging of a disease with severity, used for prognostication, and it's also used for prediction and monitoring of response to treatment of a disease process. So that's what biomarker is. Now let us come to sepsis. Let me be very clear about it. We have abused the word sepsis immensely. That means most of the clinicians use the word sepsis as a synonym of infection. So they sometimes use terms like it's a great toenail sepsis. So it shows that sepsis can be limited to the nail of the little toe of the foot without even realizing that sepsis is a generalized condition. Microbiologists, I won't forgive a microbiologist if he uses the word synonymously with septicemia. They are two completely different things. You can have sepsis without septicemia. You can have septicemia without sepsis. So, by definition, sepsis is a life-threatening organ dysfunction which is caused by a dysregulated host response to infection. So that means there are three components. We have an infection. We have to have objective evidence for that. We have an infection. Secondly, that infection starts a dysregulated response, host response, which is a combination of pro and anti-inflammatory cytokine cascades. and it is severe enough that it causes life-threatening organ dysfunction. Sepsis is always severe enough, and that's the reason why the latest definition of sepsis doesn't have a criteria called severe sepsis. So sepsis is severe by definition. We have sepsis, we have septic shock, but we don't have a severe sepsis criteria right now. And it's a complex syndrome which is characterized by physiologic, pathologic, biochemical abnormalities triggered by an infection. Okay, what are the questions which come to a clinician's mind when facing a sepsis patient? They want to know what is the likelihood of infection. Because if we don't have an infection, then it can be a sepsis-like syndrome, which was earlier called SIRS, that means systemic inflammatory response syndrome. With that term itself is questionable right now, because we know that it's not only inflammatory, we have both anti and pro-inflammatory components in sepsis. So, and then what is the severity of illness and the risk to develop shock? What are the most likely pathogens, bacterial, viral, fungal, parasitic, because therapy will depend on that. What is the most appropriate antimicrobial treatment? Is the patient improving or not, and if not, why? That is prognostication. And when can antimicrobials be either de-escalated or can be stopped? So we need some kind of a help regarding answering these questions. Well, this is from this particular recent review article, where they have nicely shown that sepsis has certain unspecific signs of infection, it has organ dysfunction, and it has a microbiologic documentation. These are the three basic components when talking about sepsis. Well, when we talk about biomarkers in sepsis, we have certain biomarkers which are pathogen specific. We specifically look for, say, by rapid antigen tests, antigen for Streptococcus pneumoniae, Legionella pneumophila, Clostridioides difficile, Cryptococcus neoformans. We have tests available for that. We sometimes look for broad groups like endotoxins for gram-negative bacterial infections. Then we have fungal biomarkers which are group specific for either candidal infection or aspergillosis. I am not going into any of those organism-specific or pathogen-specific biomarkers. What we are going to talk about is host response biomarkers today. Well, now an ideal biomarker for sepsis should help in identification of sepsis early to initiate antibiotic therapy, to differentiate it from non-infective cases with good specificity, to distinguish bacterial sepsis from non-bacterial infections of viral, parasitic, and others, and then prognostication and guiding antimicrobial therapy. Now, we know that pathophysiology of sepsis is very complex and it's incompletely understood. We do not know the exact pathogenesis. It involves activation of pro-anti-inflammatory pathways and the response to pathogen and outcome on host. So that changes the body's metabolomic profile. And identification of these metabolites, it help in diagnosis, prognosis, therapeutic intervention. But saying all those things, differentiation of septic patients from other patients with a sepsis-like syndrome due to non-infectious causes is extremely difficult, even with all the developments that have taken place standing today. Well, there are more than 250 biomarkers which have been evaluated for sepsis. And you know that when you have too many options, none of the options are really inviting enough. So when you have too many drugs for a disease, that means none of them really works well. So if it works well, we will have one or two drugs for a particular disease process. So we already have more than 250 biomarkers, which include C-reactive protein, procalcitonin, presepsin, then soluble urokinase type plasminogen activator receptor, neutrophilic CD64, adrenomedulin, and then proadrenomedulin, super estrem1, interleukins, and recent ones, the biomarkers based on omics technology like genomics. We have the cell-free DNA, we have the micro-interfering RNAs and all those coming up, transcriptomics, proteomics, and metabolomics. So let me tell again that none of them accurately differentiates between sepsis and sepsis-like syndrome, and biomarker performance in sepsis management today is suboptimal. Let me come to but some of them do definitely have a role in diagnosis and guiding clinical decision making. So let us start with the more commonly used one, the C-reactive protein. So it's an acute phase reactant, rises early in inflammatory response, including sepsis. All inflammatory responses doesn't necessarily have to be in response to an infection. It can be malignancy, it can be trauma, it can be tissue destruction of any other, it can be autoimmunity. The specificity of CRP has been repeatedly challenged. It's still among most frequently included parameters in clinical studies. The second very commonly used, most commonly used one is procalcitonin with CRP. It has been the most extensively studied, and in the earlier days, say 3-4 years back, this was considered to be the gold standard of all the different biomarkers. Newer biomarkers were evaluated against procalcitonin as a marker of sepsis, but its diagnostic efficacy and accuracy and specificity is better than CRP. But if you look at it, the levels do increase in sepsis, but the levels are significantly influenced by many factors. Like, for example, the type of infection, the site of infection, severity of illness, postoperative status, the type of surgery. Unlike CRP and procalcitonin level, unlike CRP, the procalcitonin levels, they decrease very rapidly. And therefore, though after surgery, there is for the first 24 hours surge in procalcitonin levels based on how serious the surgery is, but after 24 hours it usually falls, and that's why people they have seen that subsequent to if procalcitonin is higher, it's likely that it's an post-surgical infection rather than simply surgery accounting for the rise in procalcitonin level. So it has a better potential to recognize gram-positive sepsis as compared to gram-negative sepsis and candidemia, and sometimes may even fail to rule out bacteremia. In burns patients, it has been used successfully for early diagnosis of sepsis, but if you look at it, that PCT-based antibiotic initiation is right now in a doubtful pedestal because it has failed to show short-term mortality benefit. Rather it delays antibiotic initiation in sepsis. If you have to keep on waiting for a procalcitonin result for starting the antibiotics in a patient, then it delays the antibiotic initiation. And it's said that it's imperative to use procalcitonin in clinical context rather than as sole marker of diagnosis of sepsis. In the 2021 Surviving Sepsis Campaign guidelines, they recommend against using procalcitonin with clinical judgment to start initial antibiotics, against clinical judgment alone to minimize the delay of starting antibiotics. Now, but definitely procalcitonin has got a good role. Truly speaking, a single value of procalcitonin is much inferior to the kinetics of procalcitonin. That means serial values of procalcitonin, and therefore procalcitonin serial values have been used for de-escalation or complete stoppage of antibiotics rather than starting the antibiotics. So there are other ones also. Presepsin is one recent one which is released from monocytes following infection. Recent meta-analysis has shown that it's as good as procalcitonin for diagnosis of sepsis with a better area under curve, better sensitivity and specificity. In fact, it also correlates with the severity of the sepsis, the levels of presepsin. But the problem with presepsin is that we do not have yet a reliable randomized controlled trial to establish the role of presepsin in sepsis. It has also been found to be important in prognostication of sepsis, and it has been found that it has a potential to diagnose sepsis early, differentiate sepsis from non-infective SIRS, and optimize antibiotic initiation, provided we have good RCT-based evidence for use of presepsin. Okay. SUPAR, which is soluble urokinase type plasminogen activator receptor, called SUPAR, normally present in blood and other body fluids. It's increased in inflammation like C-reactive protein. It has a moderate diagnostic ability for sepsis like procalcitonin, but it's inferior to PCT in differentiating from non-infective SIRS. Then we have NCD64, neutrophilic CD64, which is a surface receptor on antigen presenting cells, increases in infections and exposure to endotoxin or a lipopolysaccharide. It has been found that in adult patients, NCD64 outperformed procalcitonin, CRP and IL-6 for sepsis diagnosis. It significantly increased in bacterial and viral infections. So that says that it cannot differentiate viral infection from bacterial infection. That's one of the problems with neutrophilic CD64. People have found that in critical ill patients, NCD64 plus CRP is useful for diagnosing sepsis. Okay. Then we have adrenomedulin and proadrenomedulin, which does not help in diagnosis of sepsis, but helps in prognostication of sepsis. I'll avoid going into details. So, if we look at all the other biomarkers, interleukins, STRAM1, then we have HMGB1, high mobility group box 1. Then we have bacterial permeability increasing proteins. All of them, they have truly speaking failed as diagnostic markers in larger trials. Now people are looking for, rather than a single molecule as a biomarker for sepsis, people are evaluating combinations of biomarkers, whether they can give us better result than a single molecule. So truly speaking, people found that novel biomarkers used with traditional time-tested clinical tools like CRP, like neutrophil count, has a better probability of differentiating sepsis versus non-infective SIRS. Now, at present, so what is the role? Most biomarkers, they act as an aid to clinical judgment and not its replacement. And therefore, in diagnosis of sepsis and antibiotics administration, we should consider them as an aid to clinical judgment along with the clinical judgment. So, biomarkers have always helped in antimicrobial stewardship, because it helps in de-escalation and complete stoppage of antibiotic therapy. All the biomarkers, the CRP, procalcitonin, they have found to be very good in terms of de-escalation and following up of a sepsis patient, and therefore that role is definitely there. To conclude my last two slides, sepsis and septic shock are life-threatening conditions demanding prompt resuscitation, antibiotics, and source control. Sepsis biomarkers, it's still an area of active research with newer evidence added every day. Sepsis is a result of complex interplay of various pathways, therefore single biological marker may not be the answer for diagnosis, prognostication, follow-up, guide to antibiotic escalation or de-escalation, and a combination may prove to be much better than a single molecule. Understanding sepsis biomarkers and their role in sepsis pathway can help to further rationalize sepsis management alongside clinical judgment. Now, 2021 Surviving Sepsis Campaign guidelines have recommended against using procalcitonin plus clinical judgment to start initial antibiotics, against clinical judgment alone, because waiting for procalcitonin may delay antibiotic administration. But they suggested using procalcitonin plus clinical evaluation compared to clinical evaluation alone to discontinue antimicrobials, to de-escalate and to stop antimicrobials. Biomarker kinetics are much more useful than a single value in predicting sepsis. A combination of biomarkers may have better diagnostic accuracy. An ideal marker on sepsis is yet a mirage that we continue to chase. Many which have come have turned redundant. Many still are in queue to prove their worth. Omics, genomics, transcriptomics, proteomics, metabolomics, with machine learning capability may bring out newer biomarkers and better applications in diagnosis, prognosis, and therapeutic monitoring of sepsis. So that's what I had to say. Thank you very much for your kind attention.
Thank you, Dr. Pallab. Excellently presented. Actually, I did a webinar on procalcitonin many years back, and during COVID time, we did look into multiple factors when the patient presenting in the ER, which are the patients who, we took their all the biomarkers which were done and did a modeling exercise, and we came up with 3 different models and narrowed down the biomarkers to about 8 or 9. So we truly said it's the combinations of the biomarkers which can give more information compared to just individually tested biomarkers, because we saw such a good correlation in some of the patients where procalcitonin was low but the LDH was high, but then there were other biomarkers which had higher weightage when we did the modeling, gave us more information and better information compared to just a single biomarker. I totally agree with you.
Thank you,
Dr.
Ray.
Dr. Mirdha is...
Thank you, Dr. Ray, for such an excellent presentation. Of course, this syndromic approach, what we are talking about, is about testing for the, in sense of the disease, clinical manifestation, rather than the pathogens themselves. So this definitely is how we adapt to this is really doing well, and it gives us a sense of pride that we can be so beneficial with syndromic approach for the patient benefit. Thank you so much for your nice deliberation.
An excellent critical analysis of the biomarkers has been brought out by you. So I thank you for this beautiful lecture. You have partially covered, but I have my own thinking. Can we have a permutations and combinations to segregate, as you said in one of the slides, that gram-positive sepsis and gram-negative sepsis, number 1, and bacterial sepsis and non-bacterial sepsis. As per the literature review done by you, would you highlight, if you have come across, that we can segregate to some extent, may not be 100%, but workable segregations? Can it be done amongst the plethora of biomarkers?
You are very right. We frequently have meetings for newer diagnostics in ICMR for sepsis. Now, the algorithm I always put there is, whenever we are facing a clinical syndrome, I first would like to know this inflammation is infective in origin, non-infective in origin. Non-infective, forget about it. Infective in origin. Infective, tell me bacterial, fungal, viral. And if it is bacterial, the next thing we would like to know is it a gram-positive bacterial infection or it's a gram-negative bacterial infection? Because that antibiotic list is completely different in those 2 situations. So truly speaking, there are many factors there and many pathophysiological factors which blur the situation. I tell you one thing, that let us look at endotoxin. Endotoxin came out in a big way to differentiate gram-positive from gram-negative infections. We know that we have about 1.5 kg of gram-negative organisms and gram-positive organisms in our intestine, and a certain percentage of it is dying every day, liberating endotoxin. That endotoxin is absorbed by the liver, by the venous system, goes to the liver, gets detoxified. And a very small amount is released into the body, which keeps our immune system always on the toes to look for pathogenetic physiologies. Now, Look at this situation. I give you a hypothetical situation. A person who is having a gram-positive infection, Staphylococcus aureus bacteremia, and goes into sepsis, organ failure, liver failure, the liver detoxification of endotoxin goes. And therefore, endotoxin is also released into the blood, which is coming from the normal flora, the dying organisms from our intestine. Test for endotoxin, it will be positive. Actually, it started with a Staphylococcus aureus bacteremia. So things get complicated and jumbled up in such a way that we probably require a much better diagnostic facilities for them. Definitely the cell-free, metagenomic cell-free plasma DNA, once we can have it with good turnaround time, then definitely it's going to tell us very clearly in a short time period about, because it's totally generic and it will tell any organism without any specific small list to target.
Biomarker in a situation where the blood-brain barrier is not breached. Is going to be helpful in intracranial or in the brain when the blood-brain barrier is not breached? In that situation, does biomarker have any role in the CSF?
Well, specific system-wise infection, the biomarkers, that's a totally different field. That means to look for very specifically in central nervous system infections, and in a situation where we do not have a breach in the blood-brain barrier, do we expect biomarkers to be present in blood only, not CSF, or in blood as well as CSF only? And is there additional biomarkers derived from the specialized cells in the central nervous system like astrocytes and those which take part in formation of the blood-brain barrier? A very, very important topic. Work is going on, but I have not come across any decisive thing on it, definitely.
Thank you.
Thank you very much. Thank you
so much. Thank you so much, sir, for this very informative talk. Now I would like to call Dr. Anush Sharma, sir. Sir is going to talk about AMR stewardship and AMR surveillance network. Sir is NPO, Technical Focal Point for AMR, and started working with WHO in year of 2000. Sir has co-authored and contributed in numerous WHO publications. Thank you so much, sir, for gracing us with your presence.
Excuse me, has the session changed? I mean, are we not having this panel discussion? Investigations of an outbreak or something? Achha. So do you want to change the chairperson or something? Okay, okay. That's okay.
Thank you, and I'd like to thank Dr. Hama Chaudhary for adjusting my talk in this session, and apologies to the chairs for not being aware of this. And this is just because I had another commitment back in Delhi and I had to leave. Could we have the slides? Yeah. So I will be talking on AMR surveillance and antimicrobial stewardship, how these are related. And in the outline, I will talk about, firstly, the political commitment for AMR, the linkages between AMR surveillance and antimicrobial stewardship, and what are the resources which are available, a little bit about AMR in India, AMR surveillance networks in India, and what can you do? As microbiologists, how can you contribute towards AMR containment? All of us are aware AMR is a huge problem. Everybody knows about COVID, but still if you talk to a layperson, a lot of them are not even aware of what AMR is or what is antimicrobial resistance. And you compare the mortality of COVID over the last close to 4 years, roughly 7 million. Compare it with the mortality associated with AMR. Just in 1 year, 2019, global burden of, again, these are estimates, close to 5 million, out of which 1.27 million were directly attributable to AMR. And the projection, 10 million deaths by 2050, out of which roughly 2 million will be in India. So in India, we need to be even more careful about this, because this is going to impact us much more, and not just the health system, but also the GDP. Now there is political commitment for AMR, and in the recent G20 health ministers meeting, the health ministers agreed, and AMR is a priority for the G20, and they highlighted that AMR has to be contained, and they talked about responsible use of antimicrobials through stewardship and surveillance. Even in the G20 New Delhi Leaders Declaration, the heads of state of roughly 2/3 of the world population and 85% of the global GDP identified AMR as a priority, and they talked about antimicrobial stewardship and surveillance in the paragraph on health. We are in the city of Jaipur, and I don't know, I think we've lost the presentation. But anyway, all of you are here in the city of Jaipur, which had the Jaipur Declaration in September 2011. 2011 was the year in which WHO identified AMR as a theme of the World Health Day, and later that year in September, health ministers of 11 WHO member states signed the Jaipur Declaration, identifying it as a priority and committed that they will work on AMR containment in their member states. I think the battery has we seem to have lost the presentation. Okay. Anyway, I don't need the PowerPoint slides. I'll just, if you can bear with me for another 10 minutes or so. Yeah, it started charging again. So I will talk a little bit about AMR surveillance. And when we talk of AMR surveillance, why do we do surveillance? In a simple definition, surveillance is information for action. But we need to understand how do we generate that information. That information is generated by joining the dots, individual data fields, to generate useful information. And that information can be used for increasing your knowledge, and then leads to wisdom, and you have change. And putting it in the context of AMR, the individual AST reports from the microbiology lab or individual patient prescriptions containing antibiotics, they are individual data fields. You combine them, you come up with your antibiograms and your antimicrobial consumption and use reports, or the HAI reports, healthcare associated infection reports, and your standard treatment guidelines are the equivalent of knowledge, and you have these antimicrobial policy. But to bring about the change is through antimicrobial stewardship. But again, when we talk of why we do it, the purpose of AMR surveillance. It differs at various levels. At the global level, it guides the global action plan on AMR. It guides the research and development of newer antimicrobials, which newer antimicrobials are needed. At the national and state level, again, burden of AMR at the national level, and in India, it will guide the national action plan on AMR and the state action plans on AMR. Also guides the national list of essential medicines, the national treatment guidelines, but the maximum impact and the scope of surveillance is at the facility level. In your own facility, you can actually practice antimicrobial stewardship. You can guide antimicrobial use, strengthen infection prevention and control, and monitor AMR at the facility level. So surveillance impact is maximum at the healthcare facility level. You can't practice antimicrobial stewardship at the national or the global level. Antimicrobial stewardship is at the healthcare facility level. Stewardship at the national and global level has different connotations. It's not the same thing as we know antimicrobial stewardship. A lot of resources are available on the WHO website specifically for AMR, and the global AMR surveillance system called GLASS was established back in 2015 on the basis of a global WHO's global AMR report on AMR surveillance 2014, which actually identified that AMR is widespread all over the world, but a lot of countries are not even aware of what the levels of AMR are in their country. And this initiative of WHO in establishing the global AMR surveillance system was to ensure that there is strengthening of AMR surveillance systems within countries, and a global monitoring system is in place. Now, if we look at antimicrobial stewardship, there are a number of building blocks which go into practicing antimicrobial stewardship, and surveillance of AMR is one of the building blocks. You can't practice antimicrobial stewardship if you don't have all these things. Some places you can do empirical antimicrobial stewardship, but in an ideal scenario, you need to have AMR surveillance, you need to have surveillance of antimicrobial consumption and use, you need to have HAI surveillance in place, also have a hospital formulary in place, have guidelines for antimicrobial use, an AMR policy in the healthcare facility, as well as focus on infection prevention and control through the hospital infection control committees and strengthening water, sanitation and hygiene in healthcare facilities. A number of resources are available for antimicrobial stewardship. All these building blocks for AMR surveillance, WHO endorses HUNET, which is a free software available, developed by a WHO collaborating center at Harvard. For antimicrobial consumption, there's an AMC tool, there's a point prevalence survey protocol, plus there are tools available to estimate antimicrobial consumption at the national level as well. Also, there's the essential medicines list, the AWARE classification, as well as guidelines on infection prevention and control, WASH, as well as guidelines on antimicrobial stewardship. I'll focus on two of these sort of guidance documents which are available on the WHO website. First is antimicrobial stewardship programs in low and middle income countries, which is actually a practical guide helping not just the national level stakeholders, but also the healthcare facilities in practicing and prioritizing how to implement antimicrobial stewardship. And it includes certain core elements which should be a part of it, of what all structures should be there, and also provides resources for antimicrobial stewardship. There is also the AWARE antibiotic book. AWARE stands for the WHO classification of antibiotics into 3 groups: access, watch, and reserve. This is an evidence-based guideline for treating more than 30 common clinical infections, and this provides guidance on the antibiotic to be chosen, the dose, route, and treatment, as well as separate section for children and adults, as well as not only for primary care but also in hospitals, and it includes the antibiotics in the WHO list of essential medicines and the aware classification, and summary infographics are available for ensuring that this antibiotic can be used in the healthcare facility level. Now, coming over to AMR in India, and just to give you a glimpse of how much of a problem it is, I've taken one organism, Klebsiella pneumoniae or Klebsiella species, and this is data from the two national surveillance networks, NARSnet coordinated by NCDC and AMRSN coordinated by ICMR. Both the networks have more than 40 institutions engaged in these networks, and resistance levels are extremely high. In addition, there are 3 state surveillance networks, and their reports also identify the levels of resistance both to third generation cephalosporins, cefotaxime as an example, and for carbapenems, the resistance levels are extremely high, leaving very few options available to clinicians to manage infections. Now, a lot of things have happened in India, and we have the National Action Plan on AMR, we have the Delhi Declaration on AMR, signed by 4 union ministers, 2 from health, 1 from food, and 1 from environment, saying that India will tackle this priority with a One Health approach. It's also part of the WHO India country cooperation strategy. We partnered with the Ministry of Health to develop the guidance document on developing state action plans on AMR. And I'm looking forward to Rajasthan taking the lead in coming out with the state action plan on AMR soon. The meeting was organized a couple of months ago, and the draft is ready, and we hope Rajasthan comes out with the state action plan soon. The other states which have a state action plan are Kerala, Madhya Pradesh, Delhi, and Andhra Pradesh, who have formally launched their state action plans, but work is ongoing in another 10 to 15 states and UTs. Also at the national level, we bring out 2 compilations, documents which compile resources on antimicrobial resistance, the AMR Samiksha and the IPC Samiksha, which are available on the WHO India website. These are monthly publications which summarize key takeaways from these resources, journal articles, guidelines, and other resources, along with the link to the full text of the article. In India, we have a number of surveillance networks. At the national level, we have AMRSN, the NARSnet, which also has the NACNet, National Antimicrobial Consumption Network, as a sister network. We have the GASP network, Dr. Manju Bala talked about it. We have the HAI surveillance network coordinated by the AIIMS Trauma Center. We have the National TB Elimination Program, which also monitors MDR TB, the Leprosy Elimination Eradication Program, which monitors AMR in leprosy. But we also have 3 state surveillance networks, Mahasar, CARSNet, and DENSAR. How about a network in Rajasthan? And I believe work has already started. Dr. Rajni Sharma has already done the trainings, and work is ongoing. We look forward to the annual report of RAJSAR in the coming years. Some of these surveillance reports are available online, the AMRSN report, the NARSnet report, as well as the state surveillance reports from Mahasar, CARSNet, and the NACNet reports. These are available. And NCDC, as the National Coordinating Center for AMR Surveillance for India, submits the data from all these networks to the WHO Global AMR Surveillance System. And if you look at the vision for AMR containment in India, the National Action Plan on AMR 2.0 is under development and is likely to be launched soon. Niti Aayog is monitoring this, and hopefully this will be released soon. Also, state action plans on AMR are a priority under the National Action Plan. State surveillance networks are also a priority, not just for AMR, but also the antimicrobial consumption and use networks. These are important to guide the state action plan going forward. Also, we need to look at One Health AMR surveillance in terms of across sectors, not just human health, but also AMR in food, animals, and the environment. We also need to have a comprehensive, rather than these fragmented network reports, a national AMR report or a dashboard. We need national AMR awareness campaigns, and NCDC is in the process of revising the national IPC guidelines and national treatment guidelines, and also the national guidelines for antimicrobial stewardship are being drafted. NCDC is the convener of the expert group, and WHO is providing support for this expert group. Now, coming over to, this is my second last slide, your contributions to National Action Plan on AMR and the state action plans on AMR. As microbiologists, what can you do? Your primary role is surveillance of AMR. In your laboratories, make sure that you join the dots, your data dots, convert it to useful information as antibiograms, so that your clinicians can practice antimicrobial stewardship. Also, ensure your laboratories are strengthened for testing AMR. And the third key area is infection prevention and control. Make sure HAI surveillance is in place in your hospital. Also look at a state HAI surveillance network, maybe piggybacking on the AMR surveillance network. In addition to these three core functions, you have a number of other functions where you can contribute to antimicrobial stewardship, raising AMR awareness, education and training, research on newer drugs, diagnostics, vaccines, as well as state action plans on AMR. So these are some of the roles, and I'm just sort of suggesting some of these, and I'm sure a lot of you are already involved in these. Just a reminder, World AMR Awareness Week is in November. This year the name has changed. Earlier it used to be called World Antimicrobial Awareness Week. Now it is AMR Awareness Week, 18th to 24th. 24th is the Go Blue Day. Wear blue. There are a lot of other ways you can raise awareness about AMR. A lot of details are available on the WHO website. Use the hashtag AMR and WAAW when you're posting anything about AMR online, especially during the week. I'd like to end by saying we all need to do our bit. We all need to do our part in preventing antimicrobial resistance together. Thank you very much.
Thank you, Dr. Anuj. Really great work. I think we all need to pitch in there. This is a topic really near and dear to my heart also. Question on the National Action Plan. Is there going to be a legislation for healthcare centers to have some kind of a HIS and formulary and control, and then also control of how physicians are prescribing, you know, specifically the third generation and antimicrobials or carbapenems?
A lot of work is ongoing, and India, we have legislation, we have regulations on all the antibiotics are Schedule H drugs, H1 drugs. But still in India, we find them available over the counter. So I don't think legislation is the answer. But again, commitment and prioritization will be very important. And again, globally, infection prevention and control has emerged as a priority after the COVID pandemic. At the global level, there's a global strategy on IPC in place. WHO is developing a global action plan on IPC. Subsequently, all countries will develop national action plans on IPC. And in India, we've already, NCDC has an AMR, has an IPC unit, which is under the AMR program, is already working on this. National training of trainers have already happened for all the states and UTs, and state level trainings have also happened in Kerala, Madhya Pradesh, Chhattisgarh, other states are also in the queue. Kerala and Madhya Pradesh and Chhattisgarh are also going to establish state IPC programs. So with state government ownership and leadership, a lot of work is happening, but I don't think legislation is the way forward, because legislation may be there, regulations may be there, but implementation is the key thing.
Yeah, but I think even in country like US, they couldn't move the needle without the legislation. They have legislation for health systems that they have to follow the antimicrobial stewardship programs through an infectious disease physician and HIS team. They rolled it out in 2017 to the community hospitals. And CDC is trying to push a lot of efforts for the community-based antimicrobial stewardship, but it's not taking off because there is no legislation.
I think this will be one of the key agenda items at the high-level meeting on AMR next year at the UN General Assembly. In terms of, already there was a first meeting in 2016 which has prioritized AMR at the global level. Hopefully next year, and let's hope we have legislation in India, but even without a legislation, a lot of work is ongoing, and we hope things get a push.
Yeah, I think this is a first step, because that's what they did for the community, because this is very well established in any health system. Large health systems already have it. They rolled it out to the community level hospitals. At the community level now, yes, I mean, that's right. At 2016, they've started making the awareness. So I think awareness has to come first. And once everybody is tuned into thinking process, and then I think the ultimate step is legislation, unless it's in the legislation. I mean, that's what I heard at least over there when I was trying to do things. That until it's in a legislation, it doesn't move.
I would add to this that legislation is one part. Monitoring of that is the important thing which is needed. I think that will be the mainstay in India at least. And thank you, Dr. Anuj, for this updated information on AMR. And I think, as you said, Rajasthan will also take up this, and Rajni is definitely working hard on this for quite some time now. Yeah. I think we'll be giving good results in some time. Thank you. Thank you.
Thank you.
Thank you so much, sir, for this informative lecture. Now I would request our chairperson to give mementos to our speakers. Dr. Manju Bala, ma'am. Dr. Pallav Ray, sir. And Dr. Anuj Sharma, sir. Now I would request Dr. Rakesh Maheshwari sir and Rama ma'am to give mementos to our chairperson. Okay, Dr. S.K. Singh. S.K. Singh sir. I would request Dr. S.K. Singh sir and Maheshwari sir to give mementos to the poster judges also. Dr. Rekha Bachiwal ma'am. Dr. Saroj Huja ma'am. Dr. Bhagwati Chundawat ma'am. Dr. Yogesh Singh sir. Dr. Shiva Prasad Reddy sir. Dr. Geeta Parihar ma'am. Dr. Mamta Lamba ma'am. Dr. Neeta Pal ma'am. Dr. Parul Soni ma'am. Dr. Parul. Dr. Yogesh Singh sir. Sir, can someone take on the behalf of ma'am, Dr. Geeta Parihar? Is anybody from Ajmer? I request Dr. S.K. Singh sir to give a memento to Dr. Maheshwari sir also. Excuse me, ma'am. Ma'am, can you take
Dr. Dinesh Kumar Jain.
So we are going to have a quick tea break for 15 minutes. Then we will gather here for panel discussion. Thank you.
Dr. Amit Gupta.
Listen to all of you. It doesn't end here. I've told you something to be done. You have to write. Start working on this. We will try to publish it. Thank you for all your efforts. उसका कैसे करें वो कहाँ से है? कोई आया?
Now we are going to proceed further for the panel discussion. I would like to invite Dr. Mala Chabra ma'am, consultant microbiologist, ABVIMS and Dr. RML Hospital, New Delhi. She will be moderating the session. Now I would like to invite Dr. B.K. Das sir, Dr. Pallab Ray sir, Dr. B.K. Das sir, Professor, Department of Microbiology, AIMS New Delhi, and Dr. Rama Chaudhary ma'am, Senior Professor and Director Research, NIMS University, ex-professor and Head of the Department, AIMS New Delhi. On panel discussion on investigation of an outbreak.
Good afternoon, everyone. And at the outset, I would like to thank the organizers and the RAJMICROCON chapter for having us here. And as Dr. Rama ma'am is my mentor, my guide, so she just told me ki tu aaja and you do the be a panelist and a moderator. And I wholeheartedly accepted it. And second was attraction to be in RAJMICROCON. I was in first one also and the second one also. So it was an opportunity to mark the history. So thank you so much. I take the honor of welcoming my co-panelists here who have been introduced to you. And we are going to talk about outbreak investigation. And I think this is a very, very important talk for microbiologists because of so many outbreaks that are happening in our country, and microbiologists, I think, have a huge role to play. And ma'am said that we should talk about various steps of outbreak investigation. So I will take this opportunity to first by opportunity, I worked at two important institutes, that is National Center for Disease Control for 18 years, heading the Zoonosis Division, and now I'm at Apex Tertiary Care Hospital at Delhi, that is the Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital. And why I say this is that both these hospitals have given me opportunity to investigate innumerable outbreaks. So steps of outbreaks, we must understand that it is a very complex process. So it is not that one shirt fits all. It has to be tailored to an outbreak. So you have to think. And it is a multidisciplinary team that works. So you have to work hand in hand with everybody. And it makes a difference. I will, narrate, coming to the steps. I think I will go through, I'll take an example of an outbreak and tell you what are the different steps that have to be followed for investigating an outbreak. So with any idea which is the recent outbreak, a major one that occurred in the country? Any very, very peculiar and one which is very dreaded? Any idea? The young microbiologist at the back? So I would talk about the Nipah virus outbreak that happened in Kerala recently. And I was the one of the, as I told you, this is a multi-stakeholder, multidisciplinary team that comes into picture. So a microbiologist, a public health specialist, a wildlife person, animal husbandry department people, and a clinician. So this is the team which was formed, and by default, being the senior most, I was the team lead for this outbreak. And so we got, now imagine the scenario, 6th of September, we get a call that there was, NCDC received a call that something unusual is happening and unusual deaths are happening. 12th of September, Kerala has had previous episodes of Nipah virus outbreak. So 12th of September, they find 2 other family members reporting with similar symptoms to other hospital. But they gave a history that there was death in a family with similar symptoms. So the clinicians were, high degree of clinical suspicion. They called the other hospital to find out what was the cause of death. And it was labeled as ARDS, and the person, all the last rites were done. Now there was suspicion that this was a case of 2 days fever, respiratory symptoms, going on to CNS symptoms, and patient dying rapidly. So that gave a trigger. They isolated the cases immediately and informed the center. The samples were collected and they were tested at Kozhikode Medical College. This was in Calicut, and they showed positivity for Nipah virus infection. And immediately central team was formed. A central team reached there on, 11th samples were collected, 12th central team was deputed, 13th we reached there, and by then, Kerala government had made all the committees. Now when we go, the first step is to identify, so we should understand what is an outbreak. So outbreak is any disease when its incidence increases. It could be known disease like dengue, chikungunya, etc., Zika. It could be that, or it could be, we have to approach it in a syndromic manner. Now it was only real-time PCR positive, it had to be confirmed. So you have to make a hypothesis as to what is the hypothesis, what could be these cases. So your differential diagnosis also comes in. But you think of the worst and at least start acting on standard precautions and isolating the patients. So that was the first thing we did. Then suddenly there was another, when we reached there, that very day, there was again unexpected death in a young man who died in the casualty of the hospital, another hospital. Now this is 3rd hospital. But because immediately soon we heard, we told them to collect the post-mortem samples and send it for testing. Now you see, our hypothesis was that one family person got infection and he spread to the other family members. But now who's this person? Another person who's dying. So we got his sample tested and it turned out to be Nipah positive. Now our hypothesis of family cluster changed to community. But we had to, find out the cause. So next is to establish surveillance. And this is both active and passive. Meanwhile, we got a report positive from National Institute of Virology, Pune, that these were cases of Nipah virus, which is now very scary. The previous outbreak of Nipah virus in Kerala in 2018 had 19 cases and 17 deaths. You see, so that was the scare. So everybody went into the PPE and all that. Now we had to investigate that how this unknown death, which has come out to be Nipah positive, it is multifocus. Then our strategy changes. That you have to do contact tracing and containment zones in different areas. So, and we said that somebody of the family gave the history after repeated questioning, and he told us that he came to this A hospital on the same very day when the primary case was being treated. So how to prove? He came to the casualty, but how to prove? So we took CCTV footages of the hospital and we reviewed the CCTV footages of the emergency. And you will ask me, why did you are a microbiologist, why did you go to CCTV? That was work of the epidemiologist or public health specialist. But I'll tell you what happened. Now, as we were reviewing the CCTV footages, this person had come with somebody else, one of his relatives, and just by inquisitiveness, he was looking at the person standing at little far from the bed, but looking what was being done to this primary case. And when we were looking at the CCTV footages, we realized that the primary case's son and brother-in-law, who also developed symptoms, were also in the hospital, and the small child was running in the hospital. Now you see, what is the role of microbiologists here? Immediately we realized that, and the nurse who was attending to, male nurse, his mask was hanging here. So, immediately you know that IPC practices need to be strengthened. Then and there, we told them what standard precautions were, and they have to strictly follow standard precaution. They have to revise the visitors policy so that they don't allow kids to be running in the casualty. So that is the importance, that you have to move in team and work in team. So after we did that, then contact tracing started, and each person's, now there were 4 individuals. One person who died, we don't know, we are just suspecting that he was a primary case of Nipah virus disease. His child, his brother-in-law, and one unknown person who also died. So 2 deaths and 4 cases at this point of time. So we set up the surveillance system. We made a road map of where these people visited in last 14 days. Why 14 days? Because that is the incubation period of the virus, right? That is it is up to, maximum is 21 days, but usually 14 days. So trace back 14 days and see where these people, those road maps were published by Kerala government, posted everywhere, and people were asked that whoever was there at this particular time in that area should report if they develop symptoms, or if they are apprehensive, they want some guidance. So when they said they want guidance, we have to make IC material transmission based precautions, we have to explain. And like you remember, madam was there with us when we discussed this for COVID, so much of hype of fomite transmission in COVID in first wave. Similarly, so much of hype by fomite transmission in this time, in Nipah virus. So we have to judiciously think of infective dose and devise strategies so that it does not cause panic. So that was another task that we had to do as to what messages to give in the community. Now, after we did that, now lab diagnosis, confirmation, we had identified the labs. Kozhikode Medical College was doing a good job, but they did not have a BSL-3 laboratory. So we could not tell them to do anything extra. So NIV Pune sent the mobile BSL-3 laboratory there, which tested the samples. Now, how to use that laboratory? All the high-risk contacts, asymptomatic high-risk contacts were tested in Kozhikode Medical College, whereas symptomatic patient, high-risk symptomatic patients were tested in the BSL-3 laboratory. So now again, do we test the high-risk contact? Who will answer this question? Again, microbiologist was questioned whether we should do or not. So initially, yes, but if the burden increases, we decided we will stop the testing of high-risk contacts. So now contact tracing, lab testing was established. Next task was confirmation of the source. How to confirm the source? So we were trying to figure out, so NIV sent the team and DADH, that is veterinary department sent the team, wildlife department sent the team to catch the bats, as we know these are common source. And as we were investigating, we found 2 or 3 animals, cats and dogs dying in that area for not by aging but sudden deaths. So those need to be investigated. Who will do it? That will be done by the Department of Animal Husbandry, and they send the sample to their high security laboratory in Bhopal for testing the sample. And the bat catching, because you should trace the source. How did that person get? Now when we went deeper into the history, we realized that this primary case had plantations. He had fruit trees there. And when we visited his house, where he used to visit regularly, there were bat roosting. And bats do not roost anywhere. You know, once you get into the field, you realize that bats choose their trees and all the bats will roost in one tree. other 100, 200 trees around the colonies were just not with single bat. All the bats were roosting. So it was, why it is important? Because, see, that is the area, that is why it doesn't spread just like that. So he, in his plantation, had bat roosting trees. Now, do bats secrete virus always? No. Only, and now the bats were caught, tested. As of now, 63 bat samples have been tested by RT-PCR. We got the report, they're all negative. So do we presume that this is negative? No, because bats will secrete the virus only when they are stressed. So probably some bat was stressed when this person was there, and he must have eaten some fruit, because we found a lot of fruits lying on the ground which were half eaten. And he had the habit of picking the fruits at the same time. Now, as we were doing all this, the staff nurse who was attending to this person whose mask was hanging here fell sick and developed symptoms. And similarly, another person who was attending to a patient on the next bed of the hospital also fell sick. You see, immediately they were given supportive treatment, isolated, and all of them are recovering now. The child suffered a lot. He was on ventilator, but he's now out of the ventilator. But had it been that the visitors' policy was good and they did not allow small kids running in the hospital, probably, and you could have asked me that this probably was infection at home, but he had other children and other relatives at home, probably that was the time when he was shedding the virus the most. You see, that was the idea of looking at all the video clips and looking at CCTV cameras. So we established that, and when this staff nurse fell sick, we found the sample of the primary case, which was tested because he had respiratory symptoms. His sample, VTM sample in the fridge, which was tested and found to be positive. So our entire epidemiological link was established. So we identified the primary case, and good thing was that these patients were contact, and from the primary case, only secondary cases. 5 secondary cases and no tertiary cases, because action was initiated immediately. So this was, you know, after you confirm the, now confirmation of the source is ongoing. Probably next step is you do antibodies in those bat samples, and then you have initiated the control measures. All the high-risk contacts have been, you know, quarantined for a period of time, that is maximum period of 21 days. 90% are out of the quarantine period, but some are still under quarantine. And then you have now, this virus has been sequenced by NIV Pune, and it is similar to that of Bangladesh virus, right? We have 2 strains, one is Malaysian strain, one is Bangladesh strain. Malaysian strain does not cause human-to-human transmission, whereas Bangladesh strain causes human-to-human transmission. That was another important information, that it could cause human-to-human transmission if you did not take appropriate measures. So that is how you identify and confirm. Now surveillance has to be maintained for how long till we can declare the outbreak over is twice the incubation period. Now if you take maximum incubation period for 21 days, it has to be till 42 days. You have to be on high surveillance zone. You cannot remove your containment zones till 42 days after the last case was reported. At the same time, you continue doing your contact tracing if somebody passively reports that he developed symptom in those areas where these patients had suffered. So this is how the outbreak, you know, various steps. Now these were 10 steps of outbreak investigation. They need not be done stepwise, as you saw in this. So it could be here and there, but definitely these 3. And last is documenting. Now we have to properly make the maps, document it properly, so that these documents are helpful in posteriority for, you know, future reference. And documenting also, it's important to see what are the lessons learned from this. What were the gaps and what are the, so what are the lessons learned? One is standard precautions should always be followed, and it is the responsibility of microbiologists in all the hospitals. Here, CCHF cases are reported from Rajasthan. No person will come with the label that I am CCF, I am dengue, or I am what. So standard precautions in the triaging areas. Now triage is a beautiful word which we learnt, all of us, post-COVID. So patients have to be, especially respiratory tract infection have to be triaged, and fever with respiratory tract have to be triaged, and please follow standard precautions of hand hygiene, of wearing gloves, masks while attending to the patient, and your needle stick, handling sharps. So these standard precautions have to be followed at all times to prevent the outbreaks. So lessons learned: what follow standard precautions. IEC, community should be communicated properly. Another thing I forgot was media. Media response in outbreaks is very important. You should give a clear cut, one spokesperson should be identified, and clear cut information. Truth should be told to the media, then they develop trust, and you can utilize media for creating IEC awareness in general community by giving the correct information. So those were the steps of outbreak investigation, and I think this is what is the example of One Health approach. Now, what is One Health approach? One Health approach is collaborative, multi-sectoral, transdisciplinary approach to recognize that, along with human health, animal health and environmental health are very, very important. You have to have respect for yourself, for your environment, and for the animals around you. Decrease the interface between wildlife and yourself. Because zoonosis, all the outbreaks, you take it, any outbreak. Ebola, I was involved in Ebola response. Fortunately, we didn't have any active case of Ebola in our country. Crimean Congo hemorrhagic fever, now Nipah virus, SARS-CoV-2, decrease the interface with wildlife, let them be where they are. I think these were the steps of outbreak investigation, and Madam has, so there will be multiple outbreaks. Madam has a unique experience of investigating foodborne outbreaks. I think I'll hand it over to Madam to describe as to what we do in the laboratory when we get such a report. Ma'am.
Thank you, Dr. Mala Chavda. So I will be sharing my personal experience. AIMS is the one which has an anaerobic bacteriology laboratory, and most of the places such laboratories are not available. So we got a request, it's almost, I'm talking about 1990 story, from NCDC by Dr. Rajesh Bhatia, that there has been an outbreak and they want it to be investigated for anaerobic organisms also. So that was the time when I was told that in Gujarat, there is a kind of hostel where some children had food, and after having the food, they started developing paralysis. And when they were taking and this area was very remote, so there was no hospital nearby. So then they were taking these children, which were like less than 15 years, most of them, to the hospital. 3 of them died on the way. And that was the situation when the NCDC received the samples from this outbreak. They received the food, they received the vomiters of some of the patients who were vomiting on the way, and stool samples, and we also requested blood samples. So all these samples were then transferred to AIMS New Delhi, and there we started investigating. So when we were, checking first of all, the vomiters, stool, the gastric aspirate, whatever samples we got, because in fact some of the patients who could go to reach the hospital in time were intubated, and they were having difficulty in breathing and respiration also. And there also we could only get the gastric aspirate. So all these patient samples when we received, we did the anaerobic culture, and initially we were not very sure what is going to come out of it. And we received we grew some gram-positive bacilli, and we were not sure what it is. We investigated that, and it turned out to be, as per our, that time we used to have a biochemical test, which are conventional, organism called as Clostridium butyricum. So this is an organism which is a kind of saprophyte and not reported to be a pathogenic organism. And this organism is usually seen in soil and other things. So we thought some contaminant has come because the samples have come from Gujarat and may not be possible to get something. So these samples, when we were, We had cooked meat broth where we have inoculated. And then, it is very mistake. Dr. Usha Gupta, when she resigned, when she retired, she left a book with me of avian botulism. And I was just going through out of curiosity that what organism is there. And I saw that there are certain Clostridium species which can cause avian botulism, which is also Clostridium butyricum. So I had this, kind of inquisitiveness that whether it is something to do like that. And we were very new to PCR in those days. But fortunately, we were able to procure a clone from UK, from Dr. East. And this clone had Clostridium botulinum gene in that, cloned in E. coli. So this we used as a positive control. And we tested all these Clostridium butyricum isolates we have got in stool samples, in vomiters, as well as in the food. So we got 4 samples of food, and one of the sample was sevu, which is a dry semia kind of snack, and which was, later on we came to know, which was stored in a canned this thing. And this was also served to the to all those people, all these children, when they were served the food. So it's a kind of a snack for them. So what happened that we found that these samples were having the Clostridium botulinum gene, which is Bont gene, that was positive, and we had a positive control to authenticate our results. So this was a very unique finding. We were not very sure whether it is actually correct. So we even, went on to consult some of the, experts from abroad, and finally it turned out to be the first case of the world where we reported in Clostridium butyricum the presence of Bont gene, and we showed that it can also cause botulism. And these children were those who, were on respirators. They could, by symptomatic treatment, they could survive, they could be taken care. We tried to, from that time, we tried to procure the botulinum antitoxin as well as toxoid for testing in the animals. And we established the facility where we can check any botulism outbreak if it happens. So it was very, very early in that time. And so it was like an eye-opener to us. And immediately after that, a case report came from Japan. They have reported Clostridium barretti carrying the botulinum gene. And if you know, the botulinum gene, which is a toxic gene, can be transmitted by phages or by, plasmids into from different species, from Clostridium botulinum to other species. And that is what we discovered, that there are 2 which can be transferred by plasmid to AB. These are the types of Clostridium butyricum. So that was the one which we investigated, and we reported it in emerging infectious diseases that time. And because we had the facility, then we started getting another request also. The second request came from Army Hospital, and this was the time where the adults, they had food. These were actually, that time we were not supposed to disclose, but it is published, so now I can talk. So these people had eaten at their, in the mess, and after having food, again, in these Jawans, they developed paralysis, and so much so the history was given to us that when they were walking, they were taking them to the truck. So these Jawans actually could not walk. They were dragging their legs because of the paralysis, flaccid paralysis. So that was the situation. The samples came to us, and we were like thinking must be botulism, because the history was fitting with that. They have eaten food, and they had symptoms very similar to what we have reported earlier. So we started investigating, and we were rather surprised that there was no organism isolated, no toxin detected in blood of any of the patients which the samples came to us, and all the food sample which they had was also negative. So that was a surprise to us, that how come patient is developing paralysis and we are not isolating anything. So after that it happened that just I thought, let me not finish on microbiological investigation. I had a friend in toxicology laboratory, so I passed all those samples to her. And to our biggest surprise, it turned out to be organophosphate poisoning. And this organophosphate was sprayed in the kitchen just a day before, and there was some sacks of wheat flour which was lying open. So when they were spraying this organophosphate spray, insecticide, so it happened to be that a lot of concentration went into that, and when those people who had more than 3 or 4 chapatis, because they usually have a lot of chapatis, because of their good appetite. So those who had more than 5 or 6 chapatis, they were the one who was suffering. So they had more higher dose of organophosphate, and we in fact understood there is a syndrome called intermediate syndrome, which can be caused by organophosphate and can be confusing with botulism poisoning. So these are the two incidences I thought I will narrate here. And I think, again, I will say that not only investigating right from there, we sent the team and we saw that what is happening in that particular area in the kitchen, and they realized that there was a sac which was open. And this case was published in British Medical Journal with the picture of, of that area where the insecticide was sprayed. And after that, there have been many reports from India of organophosphate poisoning also. So we just not limit, if you don't get any microbial cause, I think one should also consider any toxic or any other agent which may be there and look for such cases. So these were my experiences. Thank you.
Thank you so much, ma'am. And I tell you, this became our case study for teaching EIS officers and all. That's why I remembered that you had done this wonderful outbreak investigation, which was just out of the box at that time. So thank you. And now we have a person on my left who is very well experienced in investigating and has a whole lot of experience monitoring meningococcal meningitis outbreaks in India. And we are very, very, in Delhi, we've had major outbreaks, but after a very long period of time, So, sir, we want to listen from you. What is your experience about meningococcal, and can we have another outbreak of meningococcal meningitis in Delhi now? Over to you, sir. Yes, sir, it's there. Will somebody help for the slide with the slides, please? नहीं वो move नहीं हो रही थी. Okay. No, they were.
Is it on?
Good afternoon, everyone. Thank you, Dr. Rama, for asking me to come over. We had this, till recently we are very, after the COVID-19 scare, now we know about outbreaks, that there are infectious diseases which can cause massive life loss or fatality in the community. But it is not that this is the first time that any major outbreak has taken anywhere in India. And if you look back, one of the disease that frequently has a cyclical kind of outbreaks, which is caused by Neisseria meningitidis. But for today's discussion, what will happen is that we have been exposed to this outbreak in 2005. And I am going to take this opportunity to look at the meningococcal outbreaks that have been happening in last about 100 years so in India. And this is an infection of this outbreak that happens every 15 to 20 years in a cycle. This has not been only seen in India. This has been repeatedly happening in the sub-Saharan African countries. Every 50, and one of the major reasons is that arrival of a new mutant strain that I am going to show you in a little while, and the waning immunity. It is very important to understand that certain diseases are definitely endemic in area, like for enteric fever or Shigella bacillus dysentery, hepatitis that can happen in a particular area for a place like Jaipur or a place like Delhi. But it doesn't, these common endemic diseases may not necessarily have the ability to cause a severe outbreaks kind of scenario that happens in COVID-19. But at the same time, if you specifically talk about meningococcal meningitis, it has the ability to cause a cyclical outbreak every 15 to 20 years or so, repeatedly been shown in sub-Saharan Africa. The question is why? You realize that if somebody lives in a place like, say, Bangladesh or even Delhi, for and over a period of time, when you grow from child to an adult, we have a cumulative kind of immunity or herd immunity that we gain over a period of time through the adaptive immune response. But in case of meningococcal meningitis or Neisseria meningitis, what happens is one of the major reasons for waning immunity, herd immunity over 15 to 2 years, it goes down. Why? Because the carriers rate of this organism is very, very small. 1% that is not able to sustain the immunity that we are supposed to have in our system or in a community is not there. So there is the carrier rate, because carriers is important, it spreads from one person to another and gives the immunity. So any infection, major outbreak, will hold the herd immunity in the community by circulating in a very low numbers. That's why it's endemic. And that endemicity will give rise to over 15 to 20 years. It will maintain a herd immunity, protective herd immunity. By end of 15 to 20 years, the cases will start coming up. And this is the time after 2005. Last outbreak was in 2005, and around this time, this is about 20 years now, 20 plus years. So there is a possibility there may be another outbreak of meningococcal meningitis. Therefore, we need to keep a surveillance. We need to keep our ears and eyes very open that there could be another outbreak. I just quickly look at the epidemiology of this infection. If you look at the history of independent in India, the first documented few cases of meningococcal infection or meningococcal meningitis, either meningococcemia or meningitis. This were seen in the early 1885, 83, first documented in Alipur jail in Calcutta, subsequently Lahore, Karachi, Punjab, this area. And during the pre-independence struggle period between 1930 to 1940, there was a huge migration because there was a lot of in India. That was the time when meningococcal meningitis became very well documented. That time we used to call it cerebrospinal fluid. Subsequently, major outbreak happened in 1936, then 1966. Subsequently, the 1934, 1966, 1985. Unfortunately or unfortunately, in 1985, I was also exposed to meningococcal meningitis when working as a junior resident. Primarily, this infection, meningococcal meningitis, happens mostly in adolescent individuals, either a young individual, pediatric age group, or adolescent, 13 to 14 years. So, if you look at the case fatality rate before pre-independence, so you had in 1934, it was about roughly about 35% or so. Subsequently, between 1985 2005, the mortality has gone down because you have ceftriaxone, chloramphenicol, you have penicillin. So the slow, but we during 1985 and 2005, the organism has also started showing resistance to ciprofloxacin as well as ceftriaxone. Ceftriaxone resistant meningococcal meningitis has been reported from various parts of Africa. We have, fortunately for us, we have not seen ceftriaxone resistant, but we need to be careful about ciprofloxacin resistant. That has been extensively reported. For meningitis in the contact individuals who come in contact with a patient, ciprofloxacin is probably not advisable. Rifampicin or ceftriaxone are the ones which are advised. So in 1985, you had almost whole of the whole of the different parts of the state impacted. Almost whole of India has been covered. And interestingly, this organism actually came from China, somewhere in South China. From South China, it went to Nepal in 1982-83. Then from Nepal, it shifted to Bhutan. From Bhutan, it shifted to India. From India, along with the Hajj pilgrimage, it went to Saudi Arabia, Mecca. And from Mecca, along the Muslim pilgrimage, it went to the sub-Saharan countries. And therefore, and that's where this serogroup A, this is how transmitted and got colonized in the sub-Saharan Africa. So at that period of time, 1985 to early 2000, subgroup A, meningococcal Neisseria meningitis was the very common. Now, of course, with a very excellent vaccine against the serogroup A, the sub-Saharan serogroup A meningitis has been eradicated. Okay. The 2000 outbreak was a little bit different because normally meningococcal meningitis is a disease which is mostly prevalent in the winter period. In 1985, the outbreak that happened in all over India, it was in the winter, somewhere from October, November, December, and January. 2000 outbreak, it was a little different because it mostly affected the adults, and adolescents. At the same time, it also happened during the summer season, about end of March to July. Yeah, this is how it is. It started in April 2005, then went till July end. This is the time period, as I told you, meningococcal meningitis is basically a disease of the winter period. But here, this organism, this particular strain of serogroup A, adapted so well to the summertime that it started at the springtime, and along with the very low humidity, it spread very well till July. Once the rain started, and once the temperature subsided, disease went down. It is not that the meningococcal meningitis does not happen. It happens all the time. It is in the background. So you will invariably see outbreaks of meningococcal cases in different parts of Delhi or Jaipur once in a while. Why is that? Because there is roughly about 1% carries it in the community. So there will be always background infection. But as you see, from 1994 onward, 85, 94, there was cases of outbreak. Every few years it happened, although it's not cyclical, but major outbreak does occur in the cyclical mechanism. The other thing that you have to realize is that this 15 years of waning immunity is very important. The outbreak happened in 1985. Subsequently, over a period of time, it was endemic in the community for a long period of time. So for about 15 years, the carriers rate, which was anywhere between 1 to 12%, it raised the immunity in the community. And by 15 to 20 years, the inter-epidemic period carriers rate has gone down. Therefore, there was a waning immunity, and there is a possibility from 2005. This is about 20 years now, as I already mentioned. So there is a possibility that the immunity against meningococcal meningitis now is very, very low in almost all the states, individual in different parts of the society. So there is a possibility, because of the waning herd immunity, the outbreaks may come back. Summarizing, that why does an outbreak takes place? For any infection, it is a fight between the host and the pathogen, but in this particular case, the environment has an important role, temperature. If, as I told you, the newer strain of serogroup A adapted to the higher because of certain mutation, it has adapted to the higher temperature. It can grow in the virus, and the bacteria can survive in the higher temperature, while in the other earlier outbreaks it survived at, say, it only could survive or transmit during the winter period. But this serogroup A bacteria meningococcal meningitis strain has adapted well to the higher temperature, and probably it's a mutant new strain, and the waning immunity has gone down, and it is held by the temperature humidity of appropriate condition, and that's why the outbreak takes place. Lastly, I just want to tell you that is it possible to eradicate the meningococcal meningitis in the community? Probably not, because it will be always there as 1 or 2% as the carriers in the individual, and it will sustain the infection in the community. Although the human is the only reservoir, unlike smallpox where it was completely eradicated, but this is a condition even human, even only human is the reservoir for this infection. But probably even with vaccine will have only about 2 to 3 years of immunity induced by the vaccine. But probably so therefore only way to be aware against this disease is that you have a repeated booster dose of vaccine against meningococcal meningitis, and surveillance is very, very important. Thank you so much.
Hello. Yeah, very nicely told by Dr. Bimal Das. I initially thought that I won't describe any personal involvement in outbreak investigation, but then I got instigated by Dr. Bimal with his nice description of a not so uncommon a disease. In fact, the 1984 outbreak of meningococcal meningitis in India, which affected nearly all the states north of the Vindhyas. So that was the year when I joined my microbiology residency. And it went on for about nearly 7 to 8 years. It spilled over. And after that gradually waned off. And Dr. Bimal has very rightly said that you always have an outbreak where you have clinical cases, you have subclinical carriage, and all those things give you a herd immunity. And there is some kind of a magic number. If the population has this percentage, X percentage of the population is has developed immunity, then the organism cannot maintain itself in the community by cross transmission. And this herd immunity gradually gets disturbed, and that's what I'm going to talk to you about. After that, we kept on seeing that in Chandigarh, every year we get about somewhere between 10 to 15 cases of meningococcal meningitis only in the months of November and December, only from 3 clustered communities. One was near Saharanpur, one was in Himachal Baddi, the third is the area bordering Haryana and Rajasthan. And then we investigated those. What we found is that all these communities, these are the areas which are rapidly getting industrialized. New industries were coming up. They were hiring lots of migrant laborers who are non-immune and who disturb the herd immunity of locally. And then we found by going to Baddi that these migrant laborers, they live in suboptimal living conditions in dormitories. Like in one room, there will be some 30 to 40 people sleeping at night. And in the months of, and there is very rapid close communication and sharing of the respiratory flora amongst them. They also, because of the cold, they burn wood and sit around the burning wood with dry air, hot air. Their nasopharyngeal charring takes place, and that makes the carriage organisms invasive. So this was, we have a review article published in the 1990s on this. So that's a very interesting fact which explained to us why we get clusters of cases only during the months of November and December from 3 communities every year, and we do not get any other cases in between. Thank you very much.
Thank you, sir. Thank you, Dr. Das, for that wonderful, wonderful presentation, because it is so important. As you are aware, we were so worried, you know, the expert group, you were part of that expert group, we were so worried about, now we think that there's an impending and we have to be prepared. So if outbreak has to happen, it will happen. What will make a difference is preparedness. How prepared are we to tackle the outbreak? And you know, this experience and expertise is absolutely must to give inputs in the national guidelines as to what is the preparedness that is required. And sir, your inputs, thank you so much. You know, these things are so interesting, and that's why I say that outbreak investigation is totally different ball game. One has to be totally involved in it, not thinking, oh, this is not my work, this is not my specialty. If you are in field, you are the person, you know, whatever inputs, and respect everybody's inputs. Because sometimes a stupid thought also gives you such ideas. You know, for example, Nipah virus outbreak, we are not able to find the source as of now, but there are areca nets. And then when we were going through the file, the patient is that of psoriasis. He had psoriasis, you know. So suddenly we thought, oh, Kerala, Ayurveda, was he applying something? So we went into that history. Of course, all that was negative. The history was negative, but you know, you have to have that kind of thought process that goes in outbreaks. So thank you so much, sir, for giving that insight. And sir, now my question is to Dr. Pallab. He's past president and secretary of IAMM, and I'm posing this question to you, sir, because I think as microbiologists, what is our role in outbreak investigation, and what should we do? You know, that all of us should learn about outbreak investigation, I think, in today's era. And how can we make, as an IAMM body also, how can we make an impact on microbiologists to learn about outbreak investigation? Over to you,
Absolutely, sir. Absolutely. I feel there are multiple reasons behind it that the microbiologists do not take active part in outbreak investigation. The first problem is that microbiology, as a subject that is taught to us, we never teach epidemiology as a concrete package in the syllabus. Everybody learns epidemiology by default, by discussing with others, and there is no proper systematic training in epidemiology. We probably need to introduce that. And that is the reason why we have always dependent on public health and community medicine people for investigation of outbreaks. And truly speaking, I hope there is no public health person here. They are actually specialists of all super specializations. So, but at the same time, I tell you it with confidence that they do not know more microbiology than a microbiologist. They do not know more cardiology than a cardiologist, though they pose like that. So, microbiologists, if they are given some training in how to approach epidemiology, and they come out of their inertia to take part actively into outbreak investigations, it's extremely important that microbiologists do that. So, I will tell you one thing that's very important is at the very beginning. The first thing of an outbreak investigation is to have a case definition. So because there will be so much of noise and panic increases the noise. So, I mean, which cases actually belong to this particular cluster of cases and how they are different from, you will get fever with respiratory infection due to multiple causes, and you have to have a proper case definition so that you have only proper cases without noise. That's a very important thing. Then we need to have very good documentation of data over last few years for most of the infections to establish that we are dealing with an outbreak. So we have to define that this is an outbreak. Outbreak will depend on numbers. Outbreak will also depend on contact and secondary infections, even if the number is very small, which happens in Nipah virus infections. So that's a very, very important thing. Then we also should know how to interpret the case dynamics over time and over space, which usually is done by the public health people. How subsequent peaks of infection gives indirectly an idea of the incubation period or secondary case rate as well as the incubation period. I mean, we should learn those aspects into our microbiology teaching. So we probably, and after that, once the samples come into the laboratory, Dr. Mala has very nicely told about exactly what all to be done. There are certain commonalities and there are certain specific situations in every outbreak. There are certain specifics for each outbreak, each type of infection. So she has very rightly said, and I think I won't go into much more details about these things. Rather, we can have some comments from the audience and audience participation also.
Sure. So I think I open it for discussion. So if you have any questions, any comments, any experiences, we would like to listen from the participants. Oh, wow.
Actually, this is a good point taken up. I really understand the feeling of the students when they don't learn anything about going to investigate an epidemic, and I have had an experience. We were suddenly asked by the government to go and investigate some cases of fever. I think Dr. Rajendra, do you remember when there was an outbreak of scrub typhus? Actually, when I was given this order, I thought, what do I need to do? I didn't know. I was never trained for that. So I had, on that point of time, I had to look into what is to be done. क्या मुझे लेके जाना है? क्या मुझे वहाँ samples collect करने हैं? I mean, this is some 20 years back. But at that time, कुछ training नहीं थी. हम लोग गए हैं, जैसे कुछ किताब में और reviews वगैरह पढ़े. वहाँ जाके samples collect करें. And thanks to Dr. Rajendra, he was from the this Department of this health, I mean DMSC. So he was more exposed to the societies than I was. I was always in the medical college, so there had been no exposure. With him, we could collect the samples and then process them when we came, documented everything. That was a learning process for me, even when I was in the best medical college of the state. So it should be incorporated in the teaching, our syllabus of microbiology, because people have to face this. And especially now in COVID, we've learned a lot how the threats come up so fast and rapidly. We must be one step ahead to deal with all that.
So, yes, thank you so much, ma'am. And one thing that I forgot to mention, and you brought it up so well, is whenever you're going to investigate an outbreak, like when a central team goes, first go and get in touch with the administrators. Even in a state, inter-district, go and talk to the administrator. Unless you do that, unless you take that permission, you will not get any help. And you cannot investigate an outbreak without the local bodies. That is the first thing we do. So take the briefing, and at the end, when you finish your investigation, there should be debriefing, right? What you have done, and report has to be submitted either ways. So, any other comments?
I have...
मुझे अच्छा मौका मिला था उस वक्त में डॉक्टर नित्य व्यास जी के साथ में मैं अलवर के पास में राजगढ़ जहाँ पे फीवर केस हुए थे कई गांव में तो ब्लॉक सीएमएचओ के द्वारा हमने वो सारा एरिया टारगेट्स कवर किया उसके बाद जितने भी फीवर केस थे उनके पूरे बायोडेटाज लिए नाम है पूरा डिटेल्स एंड उसके बाद में सारा सैंपल लेके सुबह 4 बजे जयपुर पहुँचे और रात सुबह 9 बजे तक 8 बजे तक तो मैंने मैडम की टेबल पे सारे इन्वेस्टिगेशंस के लाइन लिस्ट करवा करके बिलिंग्स एंड अब HID नंबर है, पहले CR नंबर होता था, सब कुछ कंप्लीट करा के और इवन रात शाम के 2-3 बजे तक तो मैडम की टेबल पे सारे इन्वेस्टिगेशन के रिजल्ट जो फिर CBC ये जो था स्क्रब टाइप के संबंधित जो है वो एडवांस लैब में चले गए थे.
Very good, sir. आपको ये next conference में I think you should present it because or then others will also get motivated to do what you have done. That's exactly what you need.
उस टाइम 30-40 केस जो है फीवर के बनाए जो सारा सब कुछ लाइन लिस्ट किया था.
Thank you.
और मैं वैसे तो ब्लॉक CMHOs भी रहा हूँ और अभी प्रिंसिपल स्पेशलिस्ट और मैंने माइक्रोबायोलॉजी लेट की है 2012 उसमें वैसे.
Thank you for your input. Thank you so much. Last question probably, Dr. Hema, please.
No, not a question, just 2 comments. My experience in meningococcal when I was in Willingdon, like I will say Willingdon, but it's RMM Hospital, 1991. Because 92 is when I shifted to Safdarjung, but I think in winter months they used to, in pediatric units, they used to get so many turbid CSFs, but we in the lab could not grow because my lab hours till then were like 8 p.m. And they would get the patients in the night. By the time they store the CSF and send it to the lab, we could not grow meningococcus, whereas gram stain showed very nice diplococci. So we put it actually in incubator in the ER, pediatrics ER. That year I could grow 9 meningococci in the lab. So that's my personal experience with meningococci. And then for the, before joining Quest Diagnostics in US, when I transitioned there, I worked for 2 years in public health actually. And I went and joined the department in the thick of West Nile virus outbreak investigation. So another thing which I want to mention, I think which is also important, all those samples are gold mine, because you're not going to get that opportunity later on. Whenever there is an outbreak, freeze most of the specimens because you can really utilize them, helping vendors develop kits, because then I got the books from them because being in a government state lab, I couldn't get the money, but I got for the department books and everything because I donated them the samples. And also I participated in co-development, so I got a publication out of it. So that's another area I think I just wanted to share my experience.
Yeah, and I would like to share one thing. During the Zika outbreak, that's when Mala was there to support us. We were doing some screening of samples because Zika was there in the world, and ICMR had mandated that screen some samples. So we were doing the screening of samples. We found Zika, we confirmed from NIV, and during that process we started this outbreak investigation. And because it was a red alert and not many cases were reported in the country till then, so the central government, we were lucky to have Dr. Mala with us during she was there with us for two weeks and she guided us. We investigated the outbreak from where the case was positive. She had no history of visit to any place, no contact with another person. She just had a history of fever, and because it was a fever, came for dengue testing. We also checked for the Zika, came positive. And then once we started door-to-door survey of fever cases, started testing them, we found many more cases. I think we found 150 cases at that time. So that was a nice experience, how to work together with the public health people and the microbiologists. And we had the team from center. Dr. Mala was there, right there in our lab guiding us, like she just went to Kerala. So we were lucky to have her with us that time. So it was really good. And then, of course, those samples were sent to NIV, confirmed, sequence, and then later on we also did more sequencing and publication. And then eventually, because it was Zika leading to congenital malformations, led to another study with ICMR, NIE Pune. We investigated that area, and the women who were pregnant in that time, followed them up for their pregnancy, and the children were followed up for the congenital anomalies. So luckily not major, no anomaly was found. So that's just it.
I just want to add to what Pallabre sir has told. Actually, if we go to the HACC training courses, I underwent the course training in 2017 at CMC Vellore, and there is one particular session on outbreak investigation. So there are actually 6 different steps in outbreak investigation, wherein we take into consideration various epidemiological factors, and we create a outbreak curve. Okay, and basing on contact tracing and other things, and basing on that curve, we can do the analysis. Only thing is, we should encroach into even the outbreak investigation and HACC courses. That's such.
Thank you. Thank
Ma'am,
you.
actually, recent past we have seen that viruses have gone viral, be from SARS or COVID or Nipah, Ebola, and so the government is also now prepared with VRDLs. The network is spreading all over the country, but other cousins like bacteria and fungi are neglected. We have seen outbreaks with melioidosis or scrub typhus on and off multiple times with multiple morbidities and mortalities. Also, in case of fungus, Candida auris is an important pathogen which is causing outbreaks world over. So, for them, the preparedness is lacking. That is one important thing. So, when we are seeing pandemics, next could be the fungi that we have seen. So, there should be some state level or national level pandemic or epidemic or outbreak preparedness, because most of the samples get lost during this. By the time the agencies are active and they define the case, the patients are gone, the samples are gone, and then it gets delayed. So that is one point that I want to highlight.
Thank you so much. Thank you. Wonderful point. So biosafety, biosecurity of samples, as Dr. Hema pointed that out, and you are also saying, is very important. You know, that is one of the, because they, you know, you have to protect yourself. First thing in outbreak investigations, protect yourself. Only then you can, like in announcements in plane, na, mask उतरेगा पहले अपने आप को लगाओ फिर बच्चे को लगाओ या किसी और को. So first thing is you protect yourself, and similarly samples also. Take care of investigation, take care of yourself, and take care of samples so that they are not misused for various reasons. So with that, I think it's so interesting, I think so exciting that we can go on and on talking about outbreak investigation, but we are time bound and we have to close the session. I thank all the panelists here for such insightful discussions, and I thank all the audience for active participation. It has been a wonderful session. Thank you so much. Thank you.
Thank you so much to all the speakers for this very interesting and thought-provoking session. Now I would like to call Dr. Bharti ma'am and Dr. Maheshwari sir to give mementos to these speakers. Dr. Mala Chabra ma'am, Dr. B.K. Das sir, and Dr. Rama Chaudhary ma'am. from next session. Daniel, sir. Okay. After this very informative and practical session, let's move forward towards the next session, that is Hospital Infection Control and Antimicrobial Stewardship Program. To chair this session, I would like to invite Dr. Manju Bala ma'am. Dr. Manju Bala ma'am, Professor and Consultant, Apex Regional STD Center, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Ma'am is highly experienced and a very renowned name in the field of microbiology and hospital infection control. Now I would like to invite Dr. Anita Singhal ma'am, Senior Professor, Department of Microbiology, SMS Medical College, Jaipur. Okay. So we will start with the first lecture on hospital infection control by Dr. Daniel Vandrens, CDC India. That session will be online.
Can we do one thing, because we are running behind the time? If we can have panel discussion before and then later on run the video. Because Dr. Anu Sharma, he has already taken his talk, so panel discussion is left. We can start with that.
Panel discussion के लिए invite So now to move forward, one of the major concerns in today's world is antimicrobial resistance in the microbes. So we are going to start the panel discussion on the status of panel discussion. So we are going to start with the panel discussion on the status of AMSP in different hospitals of Rajasthan. For this, I would like to invite Dr. Pratibha Kale ma'am. Oh, sorry. Okay. So I would like to invite Dr. Pratibha Kale ma'am as moderators from ILBS New Delhi.
Thank you so much. I thank the organizing committee, Rama ma'am, Dr. Shama, for conducting this wonderful conference and important topic to be highlighted here, the AMSP. Dr. Anuj has described very well the components and what is the need, how are we going to plan for the AMSP network. But when we think of global things, we should act locally first. So it is very pertinent for us to think about Rajasthan and what is the status of the antimicrobial stewardship programs here. So to discuss this, today we have eminent panelists among us. We have Dr. Rajni Sharma from SMS Jaipur. May I please request ma'am to join the panel? Ma'am is very apt person for discussing this topic today because she is the nodal officer for the national program on containment of antimicrobial resistance and AMR surveillance with NCDC, and also she has been a part of IDSP network for the national health programs on epidemic prone infections. Also she is a part of the state task force to integrate and strengthen the various sections of the labs in Rajasthan, and also involved in AMR surveillance and human health as a national expert. So welcome ma'am. Our next panelist is Dr. Yogesh Gupta, who is lab head and senior consultant microbiology head infection control at Rukmani Birla Hospital, Jaipur. He is an NABL assessor, also an NABH assessor and executive council member of IAMM national body, and also an ex-secretary of IAMM Rajasthan Chapter. So definitely at the policy level, sir is going to give his inputs. We had planned for two more speakers. Unfortunately, they could not join us. And we have now Dr. Vijayalata Rastogi, doctor who is from head of the microbiology JLN Ajmer. Ma'am is actively working in the field of mycology and also bacteriology. And recently they have conducted the anti-fungal awareness week. Also, ma'am is involved in various AMSP program components. So definitely her inputs are going to guide us. So I was going through a recent report that was published, which was the subnational level of antibiotic usage in various states, and I would like to congratulate that this report, they calculated the DIDs, that is the defined daily doses per 1,000 population per day, and in that Rajasthan DIDs were less than 10, and only 3 or 4 states were there whose DIDs were less than 10. So the antimicrobial usage as such is very low here. Delhi was topping the list. It was the DIDs were more than 30, and this was the 2019 data. With COVID, of course, the antimicrobial usage was increased in these 2 years, but definitely the aware thing, that is, as sir has said, that we have to access, we have to watch, and then we have to reserve the antibiotics. So that is much more needed here. Also, the government of Rajasthan is now planning, they have conducted the National Antimicrobial Awareness Week last year in 2022, and many activities were conducted in that. So congratulations to Rajasthan for that as well. Now coming on to the local epidemiology if we talk of. So Dr. Rajni, I would like to ask you, what is the status of AMSP program at SMS Jaipur? Because SMS Jaipur is the nodal point in Rajasthan for all the major activities that are being conducted in any of the microbiology field. So what is the status at the nodal center, ma'am?
Yeah, thank you so much first of all for having me. Good afternoon everyone. And when we talk about AMR, we all know that AMR has become a global problem, and WHO has declared it as one of the 10th important public health problem. So to address that, we all know that various national AMR programs are on, and our institute, SMS Medical College, Department of Microbiology, is part of this national program since 2015. And we have been conducting various activities. Lab-based AMR surveillance is ongoing, and Besides that, antibiotic consumption, as you just talked about DDD and all, so we are doing antibiotic consumption study also on ASM software, and we are also doing point prevalence study. And these two tools are very important to know the antibiotic consumption. And we are also part of HAI surveillance with All India Institute. Dr. Purva is the coordinator. And it's really an eye-opener even for us when we started with this surveillance. Even we didn't know that our HIA rates are so high. So we started with BSI and UTI. And the advantage of getting enrolled with these surveillance programs that we came to know about our infection rates, and we then implemented or make various trainings. We carried out various trainings of infection prevention control. We trained our healthcare workers, and also by following bundle care approaches and various other IPC practices, we were able to bring down these infection rates in our ICUs. So getting involved in all these national programs and various surveillances is really helpful. So we are doing training for IPC practices, not only for SMS healthcare workers and doctors. IPC practices training is done for healthcare workers in periphery, for district hospitals, and all these programs are ongoing. And as you just said, during AMR Awareness Week, since last 2 years, we are carrying out this AMR Awareness Week, and we are giving trainings to various healthcare workers and to our staff, to our doctors. Various workshops and CMEs were carried out. And at the same time, we concentrated on public awareness also. So we carried out various activities, public awareness activities in public places, in parks where various morning walkers were coming, or some health conscious people who are doing morning cycling, or various groups. So we tried to loop in not only healthcare workers or doctors, we tried to loop in even public, because we know that we all are responsible whenever we are talking about AMR. I would like to give one example when we are talking about AMSP. As SMS is a big setup. Yes. It's almost 7,000 bedded hospital if we involve all the SMS and attached hospitals. So it's very difficult to loop in each and every department or every person. So to implement this AMSP, we started with NICU, pediatric hospital. Our J.K. Lawn Hospital is a pediatric hospital. We started this activity from NICU, and as it is, we are doing this by laboratory surveillance. We are displaying antibiograms in various ICUs. We displayed an antibiogram in NICU, and we also used respiratory panel. As a trial, we used respiratory panel, this BioFire, for neonatal pneumonia cases. And the results were really shocking. They said that our antibiotic consumption came down by 50%.
So diagnostic stewardship is also important component of the antimicrobial stewardship.
Not only surveillance, even stewardship component is very important. And right now, I'm working with NICU in Zanana Hospital, and you'll be surprised to know that by following infection control practices and following the antibiotic policy also, as per they are using antibiotics as per local antibiogram, they have stopped using combination therapies or high-end antibiotics or reserve drugs. Initially, when I started the surveillance over there, they were using these antibiotics, but they have come down to single drug, ceftriaxone, that too not in all the patients. Right. So this is really a good step when we are talking about AMSP. So at the same time, I would also like to point out that I carried out one study on surgical site infections. And if we say surgical prophylaxis, initially antibiotics were used for very, very long time. They started using antibiotics 2 days prior to surgery, and they continued till the patient was there in their ward. Okay. So after talking to them, for clean surgeries, I was able to convince them just for clean surgeries, they can stop antibiotics after a day or two. So I'm just giving these examples to point out that how AMSP is important if we want to address the problem of AMR.
Definitely it is commendable that all the components that ma'am have enlisted are the components of AMSP program. First, there is an AMSP committee that they have. They have an antibiotic policy. They are doing point prevalence. Yes. Yeah. And antibiotic consumption also they are measuring. Plus in various wards like ICUs, they are doing their prescription audits, formulary restriction, as you said, the reserve drugs, formulary restriction, and then de-escalation policy is also being followed. So definitely at SMA Jaipur, other hospitals where the AMSP is not yet in practice can have their guidance in setting up the AMSP programs. Coming on to Dr. Yogesh, what is your experience and at what is the activities that you are doing at your center?
Thank you, ma'am. In private sector, if we talk about my hospital, Rukmani Birla Hospital, regarding the AMSP, we are having the AMS committee in which we are having the clinical pharmacologist. He is not MD pharmacology, but he is DPharm. He is quite knowledgeable in regarding the antibiotics. In that committee, myself, clinical microbiologist, my admin head, medical director, all the clinical specialists, all ICU in charges were there. My nursing head, my quality heads were there. That meeting we are holding on the alternate month. In that meeting, we are discussing all the antibiotic consumption, whatever the AMSP practices which we are doing in our hospital. Regarding the component of AMSP, we are preparing antibiogram on the 6-monthly basis. That antibiogram we are circulated and discussed with all the clinicians, all the intensivists on the regular basis. On basis of antibiogram, we preparing the antibiotic policy. Antibiotic policy we are preparing on the annual basis. That antibiotic policy we are not preparing, we are preparing with discussion with the each specialty wise. That antibiotic policy is basically on syndromic basis. Either we are using which antibiotic for UTI cases in OPD, IPD and ICU cases. Pediatric, especially the NICU cases, we are having the separate antibiotic policy. Regarding the antibiotic consumption, we are doing the DDD, defined daily dose, so that we can check what is the antibiotic consumption at our hospital. That majorly done by our clinical pharmacologists. We are, apart from clinical pharmacologists, we are also having the 2-3 trainees. With the help of that, we are taking the collection of data on regular basis. We are also doing the DRI, drug resistance index, for individual microorganism wise. We are doing this for the 4 organisms, E. coli, Klebsiella, Pseudomonas and Staph aureus. So that we can check that the resistant pattern is in which direction. Usually in last 4 or 5 years, I'm checking the antibiotic resistance is increasing.
So did you find any change that the resistance is increasing, or in some of the organisms it is a different trend?
Initially the Acinetobacter is the majorly was there, but nowadays the Acinetobacter prevalence is quite low. Klebsiella resistant is initially quite sensitive, but nowadays Klebsiella resistant is in increasing trend. Regarding the E. coli and Pseudomonas, the resistant pattern is decreasing.
Definitely that helps the clinicians in guiding the empiric choices also.
Yeah, definitely.
So how do you find the adherence to the antibiotic policy or your guidance on antibiograms? Because most of the times in private setup, the clinicians are not that compliant with the policies. So what is your experience in that, sir?
Yeah, a few of ICUs, or we say few of the consultants are very much adheres to the antibiotic policy. But yes, the few super specialist doctor, basically the super surgeons, are not adheres to that policy. Usually the CTBS surgeon and neurosurgeons, that usually do not adheres. But by pediatrician, my gastroenterologist, especially my intensivist, they usually adheres. In this, I want to just highlight one case, recent one case, a young 40-year guy that admitted or shifted from other hospital. That it's case of acute pancreatitis. When the patient is landed in my hospital, is in clear-cut case of sepsis. He is having tachycardia, having fever, 2-3 spikes of fever, 100 note, 2-3. The hypotension, urine output was less. He is already on meropenem. When he shifted to my hospital, my gastroenterologist added the teicoplanin. He sent all the cultures, urine culture, blood culture. All the blood cultures comes to negative. After 2-3 days, no growth or no alarm in my bacterial that is there. Urine culture was again negative. The patient's counts is increasing. He is having the fever, 100/3, BP is falling, urine shut down. Then the clinician added the polymyxin B. Now the patient is on meropenem, polymyxin B and teicoplanin. Next set of blood culture was sent, and in the very next day that comes to be positive. We prepare the gram stain and the GNV was there. Immediately I called my intensivist and then they stopped the teicoplanin. But the meropenem and polymyxin was there and patient is in again sepsis. We subculture on the blood agar and McConkey agar, and we also put the sensitivity directly from blood culture on MHA. Next day when I came, I see the NLF colonies was there, that is delayed oxidase positive. And sensitivity to cotrimoxazole, levofloxacin, minocycline was there. Probable organism was Burkholderia capacia. I just again called my intensivist, they stopped polymyxin and start ceftriaxone, and the cotrimoxazole ceftriaxone. The counts was set. Now the patient is meropenem along with cotrimoxazole. The patient's count was settled in 2 days, no spike of fever, and patient shifted to ward, and hopefully yesterday patient was in my hospital in ward. We are planning to shift in maybe next 2-3 days.
So definitely microbiology lab has a very important role in the antimicrobial stewardship program. Maybe it is the backbone because there are multiple activities not only related to the lab diagnosis or the antibiotics resistance patterns, but the infection control part also that they have to handle along with these activities, because that is going to play an important role in the overall reduction of the infections in the hospital. And it is really commendable that your hospital is having a clinical pharmacologist. So that is an important component of the AMSP program again, because clinical pharmacology, the doses, the consumption, antibiotic consumption, everything is clearly a forte of the clinical pharmacology. So definitely that is a plus point, I must say.
Yeah, definitely our clinical pharmacologist is helping in many ways regarding the restricted antibiotic. We are having the restricted antibiotic justification form. That form is filled by our consultant. Sometimes they fill, sometimes they do not fill. For that, we have prepared a WhatsApp group in which all the intensivists, all the in charges of ICU were there. My medical admin was there, clinical pharmacologist was there, my pharmacy person was there, and I am there. A daily report from pharmacy come to pharmacologist that how many new restricted antibiotic is been administered yesterday. On basis of that list, the pharmacologist check the justification form of how many patient was received or not received. If suppose the 10 restricted antibiotic was prescribed and we receive 5 form, in that remaining 5 form is been placed on that WhatsApp group. Immediately on the same day we'll receive almost all the forms. So that initiative we have done around 4 or 5 months back. Now our justification form compliance is around 60%.
That is commendable actually. So now coming on to again a government setup from Ajmer. So we are moving towards the periphery, and now we are going to see what is the status at the periphery now. So Vijayalata ma'am, would you like to just enlighten what is the AMSP policy and how is the adherence to that at Ajmer?
Thank you, Dr. Pratibha. Thank you, ma'am, for giving me the opportunity to share from our center. I won't be able to talk so elaborately as Dr. Yogesh said, because he is in a private setup and things are already set in place. We are still at a very nascent or probably the infantile stage, I should say, but we have been doing some local antibiograms. We keep in touch with those physicians, especially from the medicine and the pediatric departments, who are really concerned about the reports, because it really helps them to prevent infection and sepsis when our report goes very promptly. We still don't have an hospital information system, HIS or LIS, all the loopholes, it was all bare open during the COVID time, because whatever we do, the things don't reach the clinicians and the patients in time, although the reports go in time. So there are many things to set in place, and we need to do a lot of work and convince the clinicians that how important the antibiogram is and the empirical therapy should go according to the antibiogram. Still we are in the convincing stage. There are certain instances where we really could, prevent at least emergence of certain infectious antimicrobial resistant bug outbreaks. I myself remembered somewhere in 2002-3, we were able to, avert the outbreak of Klebsiella pneumoniae that came out to be ESBL positive, and it was turning to be AMC and multi-drug resistant, even carbapenem resistant it was turning out to be, but we were able to avert it at a very early stage, just because we could send an early report along with the antibiogram telling them you have to give this. So that was one rewarding experience that we have. Regarding the antimicrobial surveillance program, we have been doing it since almost now 6 to 8 months, that regular antibiogram patterns are being built up, and it is being reported under the guidance of Dr. Rajni Sharma ma'am, she is the nodal officer in charge for this in Rajasthan. So we are trying to do our best from our side. The pharmacovigilance cell is quite active since 1 year at our place, so that is one positive thing that I'm seeing, that we will be at least able to have a check on the prescriptions, unnecessary prescriptions, restricted drug, whether they are prescribing. That auditing is going on. But we need to collaborate with them. We need to tell them about the antibiogram pattern. We are observing what are the, critical, the bugs that are coming up. So that needs much more effort from all of us. We still don't have an antibiotic policy. That is really sad to say, but we need to work with the administrators to convince them about this.
So thank you so much, ma'am. Your voice represents actually the status of the peripheral, maybe medical colleges or the government setups where the facilities are not available to initiate the programs and run them smoothly. So but it is commendable that you're starting with the antibiograms and disseminating the knowledge into the physicians with your awareness
I would
activities.
only like to add one more point, that even before we go towards the study of antibiograms and this, even the diagnosis, correct diagnosis itself is a problem at many of even the tertiary level hospitals like where we are all sitting. I think many of us will agree to this, because we don't even have automated systems, we don't even have automated blood cultures, we don't have automated antibiotic resistance detection mechanisms. We rely on still the conventional mechanisms with a very little staff, so you can see what sort of a quality detail is coming out. So we really need some policy making from the government side to ensure that we get all these basic things, even at the tertiary care hospitals that are away from Jaipur. And I'm sure Rajni ma'am is going to push through all this and make us more equipped to actually add quality to the work that she's taken up on her shoulders.
Definitely, because even the policymakers are maybe serious about it. Today, Dr. Anuj has also said that HUNET activities to be extended in Rajasthan as well, the networks to be extended in Rajasthan as well. So that is really a commendable step to take forward. Ma'am, how do you suggest to involve the network through these centers, various peripheral centers, and how will you guide them, and what all training activities that you can conduct for them?
Yeah, to begin with, to implement the state action plan for AMR containment, we started our activities from last year, and all committees are in place and all stakeholders are involved, they are all looped in. And we conducted first review meeting, where all stakeholders were present, not only from medical field, from other, we know AMR involved other branches also, like we say veterinary or agriculture or environmental. So all stakeholders were there. They were all made aware of what this program is all about and how everyone should contribute to contain AMR. And after this review meeting, we have formed the document, and it is in this final stages, and we are about to release that document. And Dr. Anuj and Dr. Lata from NCDC, they are constantly in touch and they are guiding us through this. And To continue with AMR surveillance, we recently conducted HUNET training. But to begin with, as there are many centers, we cannot cater all of them together. And unfortunately, as just pointed out by Dr. Vijayalata, not all the centers have proper culture and sensitivity AST testing facility. So we are planning to strengthen these activities, and we conducted HUNET training for the centers who are already have these facilities, not only for government medical colleges, but some corporate hospitals and private hospitals also.
Really, that is a ray of good hope for the status of antimicrobial stewardship program in Rajasthan. I would request Ma'am Chairperson to please give any comment or any concluding remark regarding this.
So you are winding up the session, and I will read actually, this session on hospital infection control and AMSP. First talk was by Dr. Anu Sharma, and that was before tea break, and because he had to leave. And he talked about the country perspective, what is happening, and that infection prevention and control guidelines, they are there, and which are in the process of being revised. First guidelines, they were released in January 2020, and it is good that now Ministry of Health and Family Welfare, which released the first guidelines along with NCDC and then WHO, who were contributors in that. And now they are thinking after a gap of 3 years that revising these guidelines. And because whenever we talk about anything that even during the panel discussion, we are talking about the Rajasthan perspective. So whenever anything is done, first it has to be done at the institutional level. Our panelists, they have talked about the different experiences even from the government sector and now the private hospital sector also. And anything which is done at the institutional level, then it has to further go to the state level and then to the regional level and then to the national level. That is how the program builds up and it gets strengthens. And like Dr. Yogesh Gupta also talked about that, there are some, although things, they are happening, everything is, committees are there, AMSP program is there, surveillance program is there, everything is happening. But I feel from my experience, and even all of you will agree with that, there are always lacunae at everywhere, at institutional level, at state level, even if the state action plans, they are coming up. But when we are implementing them, it really takes long, it is not easy. First thing is that they are coming up and then we have to implement. And then we have to keep on looking at the lacunae, we have to keep on doing the gap analysis to further strengthen it, to make the program better and better. And then we can think of, because things, they have really improved during these last 2 years when we look at the AMSP program. But they were 2 years before, and 2 years during COVID period, absolutely nothing much was happening, and people, they were just focusing on COVID. And during, if you see 4 years back what the scenario was, and now during these 2 years, how the things, they are improving, and they are really looking up, and everyone is striving hard for that. And we should be more in touch with, we microbiologists, we should be more in touch with the clinicians. We should be acting as clinical microbiologists. We have to keep on re-emphasizing what is required. Like Dr. Yogesh Gupta also talked about his experience, and that is in nutshell. And Dr. Daniel, he couldn't come, but his talk is there, and then they can run the video. But because there is lack of time, I feel whatever you want to discuss with our panelists or our moderator, you can talk during the lunch time. Thank you, everyone.
Thank you so much. Thank you, ma'am. Thank you to the panelists, and thank you to the audience. Thank you.
Now I would like to thank all the speakers to sharing their experiences of AMSP across the state. And I would like to thank Dr. Pratibha Kale ma'am for moderating the session, and Manju Bala ma'am for chairing the session. I would like to invite Dr. Rama Chaudhary ma'am to give mementos to chairperson and speakers.
I want to briefly review healthcare-associated infections. I want to focus on 3 phases of building an infection prevention control program, and along the way provide examples of how an infection prevention control program impacts work and also is cost-effective. In this session, I want to briefly review
After this, we are going to proceed for the lunch and now gather back after half an hour.